Thank you. Hello everyone. See whether I am audible and visible to you. Please give me a thumbs up. Hello. Hello Ravi Dutt. I am audible and visible to you. If yes, please give me a thumbs up. Then we'll start with the session. Hi PW Zindabad. Yes. So we will start with the session FMGE Accelerate. In this session, we will learn about the PYQs. Okay. And the topic related with the PYQs. Good evening, everyone. Good evening, Prashant. Hello, Irfan. मेरा नाम लो. Hello, Irfan. Hello, Ravi Dutt. So we'll starting with the FMGE Accelerate series, and we'll discuss the topic in the integrated way, and we'll focus on the PYQs and the topic related with the PYQs. Okay. So see, what is the integrated approach? The same question can be asked in the biochemistry, same can be asked in the pediatric, and the same question can be asked in the psychiatry or dermatology. Like this, the integrated between the subject is very, very important. Okay, integration in the different topics of the subject and integration among the different subjects, whether it is horizontal integration or the vertical integration, means among the first year subject or among the first year, second year, third year and the final year subject. So it is very, very important. So today we'll discuss about the important things. Take one example. The thiamine pyrophosphate was asked, it is asked the question, near about 5 questions in the NEET PG entrance examination on thiamine pyrophosphate. Near about the 5 questions. So 2 purely related with biochemistry, 2 related with biochemistry and pediatric, and 1 is related with the psychiatry. The Wernicke-Korsakoff syndrome, it is related with the psychiatry. It is related with thiamine pyrophosphate. Okay. Then if it is 5-year-old and having the symptoms of high output cardiac failure like that, so it belongs to pediatric also, and it belongs to biochemistry also. So we'll discuss the important topics, the integrated topic. Again, take one example, statins group of drugs. Statins, allopurinol, okay, warfarin. These are the drugs which are important because mechanism of action is related with the biochemical pathway. So that's why it is important. So it is interlinked with the pharmacology subject. So it is very, very important. Today we will start our session with the niacin. Then we'll discuss about the pyridoxal phosphate. So this niacin is connected with pyridoxal phosphate. How it is connected with pyridoxal phosphate? Pyridoxal phosphate deficiency causes the niacin deficiency. Pyridoxal phosphate is an important vitamin. It is an important coenzyme required for tryptophan to niacin conversion. So pyridoxal phosphate, it is related with the tryptophan to niacin conversion, NAD conversion. Okay. So then pyridoxal phosphate, it is connected with the disorder homocystinuria. So we'll discuss the homocystinuria. Yes. मेरा नाम लो. Ritik Lata. Hello. Hello Ritik Lata. Hello PW Zindabad. So we'll discuss the integrated approach. We'll discuss the topics in this way: niacin, pyridoxal phosphate, then homocystinuria. The enzyme cystathionine beta synthase. Cystathionine beta synthase. It is an important enzyme which is, if it is deficient, it causes homocystinuria. It requires pyridoxal phosphate. Okay, homocystinuria. And in homocystinuria and the methionine metabolism, methionine and cysteine metabolism, there is connection of B12 and folic acid. So we'll discuss about the B12 and folic acid. The methionine synthase reaction, there these two are connected, that is known as methyl folate trap. Okay, methyl folate trap. Now there is megaloblastic anemia. Megaloblastic anemia means megalo means larger RBCs, oval shaped larger RBCs, and hyper segmented neutrophils. This is a picture on the peripheral smear. So there is megaloblastic anemia in these two. Megaloblastic anemia. Now what is the third condition in which there is megaloblastic anemia in biochemistry? That is orotic aciduria. So we'll discuss about the pyrimidine metabolism. We will discuss about the pyrimidine metabolism. And there is one more cause of this orotic aciduria, that is ornithine transcarbamylase deficiency, which is urea cycle disorder. So we'll discuss about the urea cycle. Just wait. So we will discuss about the urea cycle and connecting link between the urea cycle and TCA cycle. We will discuss the connecting link between urea cycle and TCA cycle. Now what is the connecting link between the glycolysis and TCA cycle? Pyruvate dehydrogenase complex. And which coenzyme is required for the pyruvate dehydrogenase complex? Thiamine pyrophosphate is required for the pyruvate dehydrogenase complex. The 5 coenzymes, it requires 5 coenzymes. So that is TPP, this is the first. Second one is the lipomide. Then coenzyme A, NAD and FAD. These are the coenzymes required for these reactions. So we'll discuss about these coenzymes and vitamins related to these coenzymes. So in this way, we'll discuss the different topics for the related with the FMGE exam. Okay, starting with the first question. See, a child presents with diarrhea, dementia and dermatitis. Classical 3Ds. Diarrhea, dementia and dermatitis. Which of the following vitamin is deficient? Okay, classical 3Ds. Which of the following vitamin is deficient? So it is vitamin B3. Vitamin B3 means niacin. Vitamin C deficiency causes scurvy. Vitamin B6 deficiency causes neurological manifestations. B3 deficiency means niacin deficiency causes diarrhea, dementia, dermatitis. And vitamin B12 deficiency causes megaloblastic anemia, and it also causes subacute combined degeneration of spinal cord. So here answer is vitamin B3, that is niacin. Now what is important in the niacin? Niacin, the coenzyme form of the niacin is NAD, NADP, NADPH, NADPH. These are the coenzyme forms of the niacin. Now deficiency of niacin lead to the disorder that is known as pellagra. What are the manifestations of pellagra? 3Ds: diarrhea, dementia, dermatitis. If it is dermatitis, it can be asked in the skin, dermatology. Dementia, dementia means memory loss. Don't you watch the movie Ghazni? So it is short term, not short term memory loss. It is short term memory loss. Ghazni. Okay, dementia. Dementia. Diarrhea. Diarrhea, dementia, and dermatitis. So dermatitis typically involves the sun exposed part of the body. What do we mean by sun exposed part of the body? It involves the neck, that is known as Castle's necklace dermatitis. Castle's necklace dermatitis. And second important, it gives glow and stalking appearance to hand and feet. Glow and stalking appearance of hand and feet. Okay. Hello Akshay Purohit, good evening. So Castle's necklace and glow and stalking appearance to the hand and feet. And what are the causes of niacin deficiency? That are very, very important. So what are the causes of niacin deficiency? See, the causes of niacin deficiency. Causes of vitamin B3 deficiency. So first is the dietary deficiency. First important cause is the diet. Second important cause is Hartnupp's disease. What is Hartnupp's disease? Yes, what is Hartnupp's disease? It is defective absorption of tryptophan from intestine and renal tubule. Hartnupp's disease. Third important is the pyridoxal phosphate deficiency. Now it is typically occurs in the patient on INH therapy, isoniazid therapy, INH drug. It is prescribed to the patient with tuberculosis. So it is important for chest medicine. INH, isoniazid is the drug given in the patient with the tuberculosis. Now in the patient with INH therapy, are facing the problem of memorizing the thing. For memorizing the thing, everyone is facing the problem, because biochemistry is the volatile subject. You needs revision, you needs lot of revisions. So practice on the paper is very, very important. Yes, Rajesh, same. I am also Rajesh. So PLP deficiency, pyridoxal phosphate deficiency, occurs when INH therapy is given. And if PLP deficiency is there, it causes the niacin deficiency. How? We'll discuss that in the related with the tryptophan. Then fourth one, taking the jowar and maize as staple diet. What is the reason behind this? This jowar, it contains the leucine. It contains high leucine, and because of the high leucine, it inhibits the enzyme QPRtase, which is important in tryptophan to niacin conversion. QPRtase. So it inhibits this QPRtase and decreases the synthesis of tryptophan into NAD. And maize, the niacin which is present in maize, it is in bound form. So it is unavailable for absorption. Okay, and the fifth cause is carcinoid syndrome. What is carcinoid syndrome? It is a tumor of argentaffin cells of the GIT. Tumor of argentaffin cells of the GIT. In this tumor, the 60% of tryptophan is converted into serotonin, and all the effects are due to serotonin production. Carcinoid tumor, argentaffin cells of the intestine, 60% of tryptophan is converted into serotonin. So it is not available for formation of NAD. So less NAD formation is there. So these are the 5 important causes, and this is the top rated MCQ, among the top rated MCQ. According to me, there are 3 to 4 repeatedly asked topics. One is the niacin. Second one important topic is the Gaucher's disease. See, niacin, Gaucher's disease, second important topic. Then third important topic is the pyridoxal phosphate, then thiamine pyrophosphate, and the nitric oxide synthesis from the arginine. These are the important topics. The vitamin and minerals, each and every mineral is important. Will PDF be uploaded of this biochemistry session? Yes, complete PDF will be uploaded of this biochemistry session. Okay. So these are the 5 important causes of niacin deficiency. Now, how it is tryptophan? See, this is tryptophan amino acid. Tryptophan, it undergoes 2 pathways. Tryptophan undergoes 2 pathways. So one is the kynurenine anthranilate pathway. Don't remember the each and every step. Just remember it undergoes the kynurenine anthranilate pathway and the serotonin pathway. Okay. So in kynurenine anthranilate pathway, it will give you the kynurenine, the 3-hydroxy kynurenine is converted into 3-hydroxy anthranilate. This step is important for us. Actually, there are intermediate steps also, because tryptophan is converted into N-formyl kynurenine, N-formyl kynurenine is converted into kynurenine, kynurenine is converted into 3-hydroxy kynurenine, and it is then converted into 3-hydroxy anthranilate, and through multiple steps it is converted into quinolinate, and quinolinate will give you nicotinamide adenine, nicotinamide mononucleotide. It gives nicotinamide mononucleotide, which is converted into NAD. Now this step, it is catalyzed by the kynureninase. This is important. Kynureninase enzyme, and this kynureninase enzyme is pyridoxal phosphate dependent enzyme. So if deficiency of pyridoxal phosphate is there, this is diverted. This kynurenine is diverted for the production of anthranilate. It is diverted for the production of xanthurinate. It is diverted for the production of xanthurinate, and it is excreted in urine in pyridoxal phosphate deficiency. Xanthurinate is excreted in the urine in the PLP deficiency. And second C, quinolinate is converted into nicotinamide mononucleotide. It is with the help of quinolinate phosphoribosyl transferase. So leucine, high leucine content inhibit this QPRTase. So in this way, tryptophan is related with the production of NAD. And if there is defect in this tryptophan metabolism, it causes the deficiency of niacin. Okay. Now answer this question. Just try it. A 5-year-old child brought to the pediatric OPD with history of diarrhea, skin rashes and dementia. Which of the vitamin deficiency is most likely cause? Yes. The answer is vitamin B3, that is niacin. See the image. 35-year-old male was on maize as a staple diet. On maize as a staple diet. Think about this question and answer it in your mind or answer it in the comment box. Okay. So 34-year-old male was on maize as a staple diet for a prolonged period. He presented with diarrhea, lesion over the neck as shown in the image below. And the condition occurs due to deficiency of, this is known as Castle's necklace. Option C. Option C. This is Castle's necklace. We are discussing the niacin. Yes. Devendra Singh, option A, niacin. This diagram is very, very important. This is the frequently asked question. Diagram is very important. Again, one diagram is there which is also important. So this is Castle's necklace, dermatitis involving the sun exposed part of the body. It causes the Castle's necklace, and hand and feet, it gives the glove and stocking appearance in the hand and feet. Okay, so answer is niacin. A 35-year-old farmer on maize diet with diarrhea, dementia and dermatitis, which vitamin is deficient? The answer is niacin. See the diagram. See the diagram. Okay, here hand and this is the Castle's necklace, and hand and feet, the hand shows the gloved appearance. So it is the dermatitis involving the sun exposed part of the body. Answer is niacin. Now the second questions. Now we will move to the another question. Okay, integrated topic, how it is integrated. Now see, which of the following vitamin needs to be supplied in diet of patient with cystathionine beta synthase defect? So it is connected question with niacin. Cystathionine beta synthase. Now we are jumping from niacin to other vitamin. Okay, what should be the answer? The answer is whether it is cysteine, methionine, serine or homocysteine. If you know the pathway of methionine to homocysteine to cysteine, you can answer this. If you know the pathway, and this pathway is very, very important. This pathway is very, very important. What is the answer here? Yes, please try. Abzal, Ankit, Devendra Singh, Ankit, Olfi. Yes, try. Okay, so here answer is cysteine should be supplied in the diet. Now how? See, do you know that methionine, start with the methionine. Methionine is converted into S-adenosyl methionine, and this is universal methyl group donor, S-adenosyl methionine, and PAPS, phosphoadenosine phosphosulfate, is the universal sulfate donor. Okay, methionine is the universal methyl group donor, that is the SAM from the methionine. Okay, answer is cysteine, yes. So see, SAM is converted into S-adenosyl homocysteine. It is converted into homocysteine. Now in the methyl transferase reaction, there is methyl group which is accepted by an acceptor and converted into product. Take example of norepinephrine, it is converted into epinephrine. So a lot of examples are there. Goniodoacetate is converted into creatine, norepinephrine is converted into epinephrine, epinephrine is converted into metanephrine. So ethanolamine is converted into choline. These are the different products of the transmethylation reaction. Now this S-adenosyl methionine, it is converted into homocysteine. It is converted into homocysteine, and homocysteine is converted into methionine. So the important enzyme here is methionine synthase. Methionine synthase, and this reaction requires both. It requires B12, it requires methyl tetrahydrofolate, means folic acid, which is converted into tetrahydrofolate. Now homocysteine condenses with serine to form cystathionine. Cystathionine, and cystathionine is converted into cysteine. Cysteine plus homoserine. Homoserine. Here is the serine. So here enzyme is, see, in this step enzyme is cystathionine beta synthase, and this is cystathioninase. Okay, these are the pyridoxal phosphate dependent enzyme. Both are dependent on pyridoxal phosphate. These both. Okay, now whenever there is block in this step, see, with cystathionine beta synthase defect, if you know that this is important pathway, it is connected with methionine, it is connected with the cysteine, it is connected with the homocysteine, the important topic, it is connected with vitamin B12, it is connected with the folic acid. Connected with vitamin B12, connected with folic acid, methionine, cysteine, it is connected. So it is integrated among the different topics of the subject. It is connected with homocystinuria, which is an important disorder, homocystinuria. The typical feature, subluxation of lens, which causes the myopia. Then homocysteine, elevated homocysteine level, that causes the serious manifestation, cardiovascular manifestations. There is mental disability, progressive mental disability in this disorder, homocystinuria. Defect is homocystinuria. Homocystinuria, that is known as classical homocystinuria. So if there is defect in this, so there is elevated level of this homocysteine, there is elevated level of methionine. So methionine, homocysteine, so it is already elevated levels. So what is decreased? This cysteine will be decreased. Cysteine will be decreased. So what should be supplied in the diet? Cysteine should be supplied in the diet. Now this cysteine will go in its own metabolism. Cysteine is converted into cysteine. Cysteine is converted into coenzyme A. It will give sulfide. It will give the sulfate, and it will give the cystic acid. So also it is important in the formation of glutathione. So this is about this pathway. See, this homocysteine level, homocysteine, which is elevated here, homocysteine is elevated in this disorder. This homocysteine causes the atherosclerosis. It is atherogenic, and it causes the serious problem. It causes the serious problem. Why? It reacts with the collagen crosslinks. It reacts with collagen crosslinks, lead to the formation of the reactive oxygen species that causes the formation of oxidized LDL that is taken up by the foam cell plaque formation and atherosclerosis. So increased homocysteine level, it is related with atherosclerosis, and it is related with collagen cross-link, or it causes the defective collagen cross-link. It also causes the it affects the lens. It affects the lens, so that causes ectopia lentis. It affects the suspensory ligament of the lens, and that's why the subluxation of lens occur. Subluxation means partial dislocation. So subluxation of lens occur. So that is known as ectopia lentis. Condition is known as ectopia lentis in homocysteine urea. Now this homocysteine, it is converted into methionine. Always draw this reaction in upward direction. Homocysteine to methionine. Always draw this reaction in upward direction. This is B12 dependent reaction. In this reaction, methyl tetrahydrofolate is converted into tetrahydrofolate. Methyl tetrahydrofolate is converted into tetrahydrofolate. So if there is deficiency of B12, it also causes the deficiency of folic acid, because folic acid get trapped as methyl tetrahydrofolate. That's why it is known as methyl folate trap, because there is no other use of methyl tetrahydrofolate other than this reaction. So it get trapped. So there is functional folate deficiency, that is known as folate trap. And this deficiency of B12 and folate, if these are deficient, that causes the manifestation in the form of megaloblastic anemia. See, now the question number 3. Macrocytic anemia. Okay, try to answer, Devendra Singh. Try to answer this. Macrocytic anemia with increased excretion of methylmalonic acid is seen in deficiency of. Increased excretion of methylmalonic acid is the hint here to differentiate between the vitamin B12 and folic acid. There are 3 causes. There are 3 causes of megaloblastic anemia. One is the folate deficiency, second one is the B12 deficiency as far as biochemistry is concerned. Folate deficiency, B12 deficiency, and third one is the orotic acid urea, which is defect in the pyrimidine metabolism. So what is the answer here? Methylmalonic acid excretion in the urine. So here answer is B12. Answer is B12. How will you differentiate between these two conditions? Now see, B12, it is important for 2 reactions, 2 coenzymes of B12. It is present in the food of animal origin. So 2 coenzyme form. One is the adenosyl B12 and second one is the methyl B12. Methyl B12. So this is required for methylmalonyl coenzyme A mutase reaction, which is important reaction in gluconeogenesis in conversion of propionyl coenzyme A to the succinyl coenzyme A. Okay, methylmalonyl coenzyme mutase. And methyl B12, it is important for methionine synthase reaction. We already discussed this reaction, methionine synthase reaction. Okay, we already discussed this reaction. Now we will discuss this reaction. Okay, so which fatty acid will give you glucose? Yes, which fatty acid will give you glucose? You know that even chain fatty acid cannot give you glucose, because this reaction, that is the pyruvate to acetyl coenzyme A, is the irreversible reaction. So even chain fatty acid does not give you glucose. Which odd chain fatty acid will give you glucose? Propionyl coenzyme A. And it is one of the substrate for gluconeogenesis. Propionyl coenzyme A, it is converted into methylmalonyl coenzyme A. Methylmalonyl coenzyme A, and this methylmalonyl coenzyme A, it is converted into succinyl coenzyme A, and it enters the TCA cycle. It enters the TCA cycle. Now the methylmalonyl coenzyme mutase is required for this reaction. Methylmalonyl coenzyme A mutase. Methylmalonyl coenzyme A mutase is required for this reaction. Okay, this is B12 dependent reaction. And if it is blocked in this reaction, there is increased accumulation of methylmalonic acid and this is causes the inhibition of fatty acid synthesis. It causes demyelination. It causes demyelination. It affects the myelination of the nerve fiber. Methylmalonic acid, it affects the methylmalonic acid, it affects the fatty acid synthesis. So that malonic acid, methylmalonic acid, it is excreted in urine, that is known as methylmalonic aciduria, and it causes damage to the nerve fiber demyelination, that is responsible for subacute combined degeneration of spinal cord in the B12 deficiency. This reaction is also important. What is the use of this reaction? So this is propionyl coenzyme A, propionyl coenzyme A carboxylase. Carboxylase. It is biotin dependent reaction. Biotin dependent reaction. So propionyl CoA carboxylase, acetyl coenzyme A carboxylase, then pyruvate carboxylase. These are the biotin dependent carboxylase reaction. It requires ATP, it requires biotin A, B, C. CO2. ATP, biotin and CO2, it is required for the carboxylation reaction. So biotin, and there are also biotin independent reaction that are also important. What are the biotin independent reaction? Wait. See this MCQ and we will discuss the biotin independent reaction first. Biotin independent carboxylation reactions. Independent, biotin is not required. One is the urea cycle, CPS1, pyrimidine synthesis, CPS2, then amino imidazole ribosyl 5-phosphate carboxylase, carboxylase, that is AIR carboxylase, and gamma carboxylation of by vitamin K. These are the biotin independent, they does not require biotin. Biotin dependent reactions. So biotin dependent carboxylation reaction. So this is very, very important. All of you should know the important coenzymes and important reactions catalyzed by that coenzyme. So all of you know that thiamine pyrophosphate oxidative decarboxylation. Then riboflavin, it is important for the dehydrogenase. Then NAD, it is important for the dehydrogenase. The important reactions are the pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, and branch chain keto acid dehydrogenase. Okay. Then the after B2 and B3, the B5 coenzyme A, it is also important for this dehydrogenase acyl group transfer, it is required. Then pyridoxal phosphate, it is important in transamination reaction, transsulfuration, decarboxylation reaction. Biotin, it is carboxylation reaction. Folic acid in the 1 carbon metabolism, and B12, we already discussed the 2 reactions related with the B12. So biotin dependent reaction, it includes pyruvate carboxylase, then acetyl coenzyme A carboxylase, and propionyl coenzyme A carboxylase. Propionyl coenzyme A carboxylase. This is important reaction in gluconeogenesis. This is also gluconeogenesis from odd chain fatty acid, and this is important reaction in fatty acid synthesis. Okay, so these are the reactions. Now coming to this question, megaloblastic anemia with increased excretion of PGLU, farm-aminoglutamic acid, in histidine load test. Okay, megaloblastic anemia, what is the cause? Here B12, folic acid, riboflavin or niacin. Riboflavin deficiency, we'll discuss the riboflavin deficiency. Niacin we already discussed, diarrhea, dementia, dermatitis. And riboflavin deficiency, it causes the all conditions, means chillosis, glossitis, magenta tongue, then the circumcorneal vascularization, seborrheic dermatitis, like that, the riboflavin. Okay, the folic acid causes megaloblastic anemia, B12 deficiency causes the megaloblastic anemia. The answer is folic acid. So See this? This is the normal shaped RBC. This is the RBC, oval RBC, and the larger in shape, megaloblastic RBC, and hyper segmented neutrophils. This is a classical feature of megaloblastic anemia. Just wait. There is no space. Okay. So, how will you differentiate between B12 and folic acid? We already discussed that B12, it requires B12, it is important for B12. It is there is excretion of methylmalonic acid. Here there is excretion of FIGLU. It is reaction. Which reaction it is required? So folic acid is important for 5 reactions. How many reactions are there? 5 reactions. If you know the number, you can try to recollect the 5 reactions. If you don't know the number, you cannot recollect the 5 reactions. So it is required for the 5 important reactions. Okay. So first reaction is conversion of glycine into serine. Folic acid, conversion of glycine into serine by the serine hydroxymethyl transferase. Second important reaction is methionine synthase. We already discussed that methionine synthase reaction. Third important reaction is C2 and C8 of purines. It is important for C2 and C8 of the purines. Fourth important reaction is important for thymidylate synthesis. And the fifth important reaction is this. It is important for conversion of histidine to FIGLU, that is farm-aminoglutamic acid. It is actually required for this reaction. FIGLU is converted into L-glutamate. If there is block in this reaction, there is excretion of farm-aminoglutamic acid in the urine in the histidine load test. Okay, so megaloblastic anemia, how will you diagnose the megaloblastic anemia? The hypersegmented neutrophils, large size RBCs, then MCV, there is increase in the MCV, decrease in the hemoglobin level. Okay, then excretion of FIGLU in the urine if it is due to folate deficiency, excretion of methylmalonic acid, and the causes related with subacute combined degeneration of spinal cord, that is B12. Okay, now see the next. A vegetarian patient, vegetarian patient present with anemia and hypersegmented neutrophils. The most probable diagnosis is vegetarian patient, means he is getting the folic acid, but there is lack of B12. B12 is present in the animal food. Now try it. What is this? Anemia and hypersegmented neutrophil. Answer is yes. What is answer? It is megaloblastic anemia. So this is the blood picture. The large size oval RBCs and the hypersegmented neutrophils. It is megaloblastic anemia. Now next question. 25-year-old person came with complaints of fatigue. It came with the complaints of fatigue and tingling sensation in the lower limb. Fatigue and tingling sensation in the lower limb. On examination, his position and vibration sense were reduced. So this part is difficult for me for biochemistry concern. Okay. Now his attending physician diagnosed. Okay, diagnosis is given subacute combined degeneration of spinal cord. Now it is easy for me. Subacute combined degeneration of spinal cord. So which of the following is responsible for the same? Yes, answer Devendra Singh. B. B12 is the answer. Yes, B12 is the answer. Think about vitamin C, it causes the scurvy. Scurvy doesn't causes the paralysis, it causes the pseudo paralysis because of joint effusion in the chronic stages. In the severe deficiency, scurvy, vitamin C can causes the arthritis and pseudo paralysis. Okay, this is not pseudo paralysis. The diagnosis is given here. Okay, iodine deficiency causes the iodine deficiency goiter, enlargement of thyroid gland in search of iodine. For trapping the iodine, there is enlargement of thyroid gland. Thiamine deficiency, it causes the beriberi, whether it is dry beriberi or wet beriberi. Okay, here the diagnosis is given subacute combined degeneration of spinal cord, it is B12. So why there is damage to the spinal cord? Because B12 there is increase in methylmalonic acid or methylmalonic acid urea, okay, and increased level in the blood also. That's why methylmalonic acid urea is there. So this causes the damage. Methylmalonic acid affect the fatty acid synthesis, lipid synthesis. It affects the myelination process. So that's why it leads to the subacute combined degeneration of spinal cord. Okay. So the answer is vitamin B12. Vitamin B12 is found maximum in. So try to answer this. This is easy question. Vitamin B12 is found maximum in. Yes. It is found maximum in animal products. Folium, folic acid, foliage. It is present in the leaves. Folic acid present in the leaves. Animal product, it is vitamin B12. Okay. And the absorption, remember the absorption. Okay. Remember this trick. Iron and folic acid is given to the pregnant lady. Iron and folic acid is given to the pregnant lady. Okay. And the B12. How they are absorbed? Iron, folic acid, B12. Iron, it is absorbed from the duodenum. It is absorbed from the duodenum. Folic acid, it is absorbed from the jejunum and duodenum. Jejunum and duodenum. And B12, it is absorbed from the ileum. It is absorbed from the, so duodenum, jejunum, ileum, iron, folic acid, B12. Okay. So this is important to remember. So we give the iron and folic acid supplementation to pregnant women for the prophylaxis of to protect them from the anemia, and then B12. So duodenum, jejunum, ileum. So animal products is the answer. The micronutrient that is deficient after ileal resection. Resection means removal. Removal of the ileum. Just now we discussed after removal of ileum. Ileum, it is C. Iron, folic acid, B12. Duodenum, jejunum, and duodenum and the ileum. So it is deficiency of B12. So answer is B12. The next question, see, an 8-year-old girl presented to the clinic with megaloblastic anemia and failure to thrive. Now we are shifting from one topic to another topic. Failure to thrive. The urine was positive for presence of orotate crystals. Presence of orotate crystals. This is a clear-cut diagnosis. Orotate crystals excretion. It occurs in the two disorders. The first one is the orotic aciduria. Orotic aciduria, and second one is ornithine transcarbamylase defect, that is type 2 hyperammonemia. Type 2 hyperammonemia. First answer this question, try to answer this question. It is a case of orotic aciduria. Now you don't know the diagnosis. Now what are the enzymes which are deficient in the orotic aciduria? What are the enzymes that are defective in orotic aciduria? Yes? What is answer here? It is somewhat difficult question. So here answer is O2. One is OPRTase, that is orotate phosphoribosyl transferase, and OMP decarboxylase. See, HGPRTase deficiency causes the Lesch-Nyhan syndrome. HGPRTase deficiency causes Lesch-Nyhan syndrome. What is Lesch-Nyhan syndrome? X-linked disorder typically affect the male having the irresistible burst to bite their fingers and lips in small amount during the period of stress. All of you have the habit to bite your fingers, but here it is severe. the self-mutilating behavior. Okay, it can cause bleeding. Okay, so it is severe nail biting, self-mutilating activity, that is HGPRTase deficiency, that is known as Lesch-Nyhan syndrome. PRPP synthetase overactivity is related with gout. Okay, adenosine deaminase deficiency causes severe combined immunodeficiency where T cell and B cell both are affected. Severe combined immunodeficiency, and the gene therapy was tried against the SCID, adenosine deaminase defect. So one left, that is OPRTase and OMP decarboxylase. This causes deficiency of this causes the orotic aciduria. Now we will discuss the pyrimidine metabolism. If you remember the enzymes of pyrimidine metabolism, you can definitely draw a pyrimidine metabolism pathway. So which is particularly important to remember the orotic aciduria, and again it is important for the CPS2. So here answer is OPRTase and OMP decarboxylase. Now just try to remember the enzymes. CAD, this is multifunctional enzyme, then dehydrogenase, then O2. These are the enzymes CAD, dehydrogenase, O2. This is multifunctional enzyme, this is bifunctional enzyme, and this is dehydrogenase. So this is carbamyl phosphate synthetase 2. One is present in the urea cycle. This is cytosolic enzyme. Urea cycle CPS1 is the mitochondrial. CPS1 requires NAD. It does not require NAD. It requires PRPP. So A for aspartate transcarbamylase. D for dihydroorotase, then orotate dehydrogenase. Yes, dihydroorotate dehydrogenase, then OPRTase and OMP decarboxylase. These are the enzymes required for the pyrimidine nucleotide synthesis. Now how the synthesis will occur? See, CO2 plus glutamine forms the carbamyl phosphate, which is converted into carbamyl aspartate. By condensing with the aspartate. So enzymes here are, it is CPS2, it is aspartate transcarbamylase, then dihydroorotase. Okay, it forms dihydroorotate. Then dihydroorotate dehydrogenase will convert it into orotate. Then orotate, OPRTase, orotate phosphoribosyl transferase, will convert orotate into orotidine monophosphate, and this orotidine monophosphate is converted into UMP, and this UMP will give you the CMP, TMP. It will give the, this is uracil, okay, uridine monophosphate. Uridine will give you cytidine monophosphate. It will give thymidylate. It will give the, so 3 pyrimidines are synthesized here in this pathway: uridine, cytidine, and thymidine. Okay, so they are synthesized in this pathway. Uridylate, cytidylate, and thymidylate, they are synthesized in this pathway. So deficiency of these OPRTase and OMP decarboxylase. This is bifunctional enzyme. Deficiency of this causes the orotic aciduria. What are the features of orotic aciduria? This is important question. Orotic aciduria, it is related with pyrimidine metabolism. So it is very, very important. So there is excretion of orotate. So excretion of orotate in urine. Then second, failure to thrive and difficulty in weight gain. Then as it affects the pyrimidine nucleotide synthesis, it causes megaloblastic anemia. Why there is megaloblastic anemia? And next one is remission with uridine. If uridine is given in the treatment with uridine, these are the features of this orotic aciduria. Okay, why there is megaloblastic anemia in? Why there is megaloblastic anemia in B12 deficiency, folate deficiency, and this orotic aciduria? Because they are important for nucleotide synthesis. As nucleotide synthesis is reduced, DNA size will be reduced, decrease in the size of DNA, and that causes the inhibition of, means cell growth is arrested in the S phase of cell division. So it is arrested in the S phase of cell division, and because of defective DNA or decreased DNA synthesis, and cell grows without cell division. Without cell division. Cell grows without cell division. That causes megaloblastic RBCs, means larger cytoplasm and smaller size nucleus that gives the megaloblastic appearance are larger RBCs. So this is why, because of this deficiency of this defective synthesis of nucleotides, B12, folic acid, orotic aciduria, there is megaloblastic anemia. So see these figures, see the figures. Self-mutilating activity. A mother came to OPD with 14 years old mentally retarded boy. Mentally retarded boy. Boy is very, very important because it is X-linked recessive disorder. Complaining of joint pain, irresistible urge to bite his fingers and lips, and the serum uric acid level was found to be elevated. In small amount, this habit is present in everyone during the cricket match, particularly during the cricket match. Okay, so but it is severe in the Lesch-Nyhan syndrome. Okay, so it is self-mutilating behavior. See, so I already told the diagnosis to you. Now answer this question: which enzyme is deficient here? Answer this question: which enzyme is deficient here? Yes, it is HG-PRTase. HG-PRTase, it is an enzyme which is important in the purine salvage pathway. Purine salvage pathway. This pathway is important than the de novo synthesis of purine nucleotide because it is typically important. It is important in RBCs and it is important in brain. It is important in RBCs and it is important in the brain. Purine salvage pathway. They are dependent. Brain and RBCs, they are dependent on the salvage pathway. Okay. PRPP synthetase overactivity is related with the gout. OPRTase and OMP decarboxylase, it is related with the orotic aciduria. Adenosine deaminase, it is related with SCID, severe combined immunodeficiency. So, whether I am audible or not, so no comment since. Yes, please give the thumbs up. Anyone who is watching? So we'll discuss that the purine salvage pathway. So in this purine salvage pathway, the defective enzyme is hypoxanthine guanine phosphoribosyl transferase. It is the deficient enzyme hypoxanthine guanine phosphoribosyl transferase. Okay. So we'll discuss this purine salvage pathway. Yes, please give the reaction in the comment box. Anyone who is watching. D. Shubhi, Dr. Devendra, Ashutosh Kumar Maurya, Devendra Singh. Anyone? So we are in a discussion of Lesch-Nyhan syndrome. Lesch-Nyhan syndrome. This is X-linked disorder typically affect the male. X-linked disorder typically affect the male. Characterized by aggressive behavior, self-mutilating activity, hyperuricemia. Aggressive behavior, self-mutilating activity. Yes, thank you. Thank you, Ashutosh. Aggressive behavior, self-mutilating activity, and the hyperuricemia. There is defective enzyme hypoxanthine guanine phosphoribosyl transferase. This enzyme, it is required for conversion of hypoxanthine to inosine monophosphate and guanine to guanosine monophosphate. So it is important for nucleotide synthesis, HGPRTase. The PRPP is required for this step. PRPP is required, which is converted in inorganic pyrophosphate. So as the nucleotide synthesis is decreases, and it is important pathway in the brain and RBCs. So that causes the neurological manifestation in the form of self-mutilating activity. Okay. And hyperuricemia is there because this PRPP accumulates, it is diverted for the de novo synthesis of purine nucleotide, and purine nucleotide degradation will give you uric acid. So there is hyperuricemia in the Lesch-Nyhan syndrome. Okay. Next, question number 11. A 50-year-old man, chronic alcoholic and smoker. So alcohol metabolism is very, very important. Alcohol is not important, but alcohol metabolism is very, very important. What do you think? What is alcohol? Whether it is food, poison, what is it? It is food, it is drug, it is poison, depending upon the concentration, alcohol. So it is very, very important in biochemistry. A 50-year-old man, chronic alcoholic and smoker, came to hospital with complaint of severe pain in the great toe. On examination, his first metatarsophalangeal joint was inflamed. He had history of similar episodes in the past. Laboratory investigation shows increased level of serum uric acid, that is 10 milligram per deciliter. What is your probable diagnosis? What is your probable diagnosis here? It is a case of gout. What is gout? See the diagram. It involves the first metatarsophalangeal joint. This is involved. First metatarsophalangeal joint. And when it is involved, it is known as podagra gout. It affects the cooler areas of the body, and because the first metatarsophalangeal joint is involved, there is severe pain in the great toe, that is excruciating pain. This is due to accumulation of uric acid crystal, that is monosodium urate crystals in the joint. That causes the formation of tophus. This is known as tophus formation or tophi formation. Okay. When in alcohol metabolism, there is increase in the NADH level. In alcohol metabolism, there is increase in the NADH. So which favors the formation of this monosodium urate into uric acid. This is the soluble form. This is less soluble form. Uric acid is less soluble as compared to monosodium urate. So it is less soluble and more precipitable. So it precipitates, causes the tophus formation. What is the confirmatory test for the gout? Aspiration of synovial fluid and microscopy is the important for the diagnosis of gout. The negatively birefringent crystals, they are important for the diagnosis of the gout. So there are multiple causes of the gout. If it is defect in the purine nucleotide metabolism, or if it is defect in the purine nucleotide metabolism, it causes primary gout. The causes are increase activity of PRPP, phosphoribosyl pyrophosphate synthetase, then glutamyl amido transferase, then increase activity of glutathione reductase, then decrease activity of glucose 6-phosphatase. This is in the von Gurk's disease. Glucose 6-phosphatase enzyme, it is enzyme of von Gurk's disease, and decrease activity of HGPRtase. That is the purine salvage pathway, that is the Leishnian syndrome. So Leishnian syndrome, von Gurk's disease, and increase activity of these three. How? See, ribose 5-phosphate is the precursor molecule for the purine nucleotide synthesis. The first step, it is catalyzed by this first enzyme, PRPP synthetase. This is the first enzyme, PRPP synthetase. It will form phosphoribosyl amine. So it is converted into, then it is converted into the different compound. So sorry, this is here, wait, eraser. So ribose 5-phosphate, it is converted into PRPP, phosphoribosyl pyrophosphate, and this phosphoribosyl pyrophosphate, it is converted into ribosyl amine, phosphoribosyl amine. So these two reactions are very, very important in the IMP synthesis, inosine monophosphate synthesis. This is catalyzed by PRPP synthetase, and this reaction is catalyzed by glutamyl amido transferase. So these are the two important reactions in the synthesis of inosine monophosphate, which is immediate precursor for the synthesis of ATP and GTP, means AMP and GMP. Okay, so this increased activity of this and increased activity of second enzyme, these are the causes of the gout. Third one is the glutathione reductase, which causes the conversion of NADPH into NADP. Glutathione reductase. Third, glutathione reductase. So it is utilized by the HMP shunt, and HMP shunt will give you the ribose 5-phosphate. So this is the third. Then glucose 6-phosphatase, von Gurk's disease, glucose 6-phosphatase, as it converts the glucose 6-phosphate into glucose. What is the MCQs? What are the MCQs related with glucose 6-phosphate? It is absent in the muscle. Then it is related with the glycogenolysis. It is the enzyme of glycogenolysis, also gluconeogenesis. The enzyme for both pathway, glycogenolysis and gluconeogenesis. So glucose 6-phosphate is converted into glucose. Okay, if there is block in this enzyme, there is accumulation of glucose 6-phosphate, which is diverted for the HMP shunt. HMP shunt, there is production of ribose 5-phosphate, and in the synthesis and degradation, there is increase in the uric acid level. HGPRtase deficiency, there is increased level of PRPP, which is diverted for the PRPP. It is diverted for the purine nucleotide synthesis. So these are the primary causes of gout, and secondary causes, that includes, the secondary causes includes, it includes cancer, leukemia, psoriasis, renal failure, cancer, chemotherapy, etc. That causes the secondary gout. Okay, so it is important disease. A person with pain in first metatarsophalangeal joint. Try to answer this question. A person with pain in first metatarsophalangeal joint of toe and increased uric acid was prescribed a drug. A drug is prescribed. Okay, on which enzyme will it work? So this is connecting link between the biochemistry and pharmacology. Okay, So on which enzyme it will work? Xanthine oxidase, HGPRTase, adenosine deaminase, thymidylate synthase. Which enzyme it will work? It will work on the xanthine oxidase. This is the answer. How it work on the xanthine oxidase? So in the gout, this is a case of gout, person with pain in first metap or tarsophalangeal joint. So in the gout, there is increase in the uric acid level. To decrease the uric acid, we use the drug that is known as allopurinol. This is nucleotide analog which is used as a drug in the treatment of gout, allopurinol. It is a competitive inhibitor of xanthine oxidase enzyme. Competitive inhibitor of xanthine oxidase enzyme. Okay, along with the competitive inhibitor, it is also a suicide inhibitor of xanthine oxidase, and it decreases the uric acid level. How it will decreases the uric acid level? See. So in the purine degradation, there is formation of hypoxanthine and xanthine. So this is hypoxanthine, xanthine, and it is converted into uric acid. This reaction is catalyzed by xanthine oxidase. This reaction is catalyzed by the xanthine oxidase. Both reactions are catalyzed by the xanthine oxidase. Now this is a drug which is given in the treatment of gout. It inhibits the xanthine oxidase. It is structural analog of hypoxanthine and inhibit the xanthine oxidase by the competitive inhibition. But along with this xanthine oxidase enzyme, it causes the conversion of this allopurinol into alloxanthine. And this alloxanthine is a powerful or potent inhibitor. It is a more potent inhibitor of this xanthine oxidase. Means this is known as suicide inhibition. Okay, खुद के पैर पे कुल्हाड़ी मारना, suicide inhibition. Okay, this xanthine oxidase converts allopurinol to alloxanthine, and it is a more potent inhibitor of xanthine oxidase. That's why it is known as suicide inhibition. So it is example of competitive inhibition. Competition, there is competition between substrate and inhibitor. Don't you watch the movie that is the Three Idiots? Don't you watch the movie Three Idiots? In that there is competition. So what Ramalingam does? Okay, he circulate the magazine during the exam period, so to inhibit the performance of his competitors. Okay, so this is competitive inhibition. The allopurinol is structurally similar to that of hypoxanthine, decreases the uric acid formation, and also by the suicide inhibition. Now we will move to the enzyme topic. Which of the following is true regarding non-competitive inhibition? Which of the following is true regarding non-competitive inhibition? Non-competitive. So remember, all of you remember one thing in this Vmax and Km, related with the Vmax and Km. There is nothing like decrease in the Vmax. Vmax means maximum velocity. Vmax means maximum velocity. There is nothing like decrease in the Vmax. So first rule out the decrease in Vmax option. Decrease Vmax. In any type of inhibition, there is not. Sorry. There is nothing like, this is the maximum velocity. Vmax means maximum velocity. There is nothing like increase in Vmax. You cannot go beyond the maximum velocity. If the speedometer of your bike showing the 180 is the maximum velocity, you cannot go above 180. Got it? So this is the maximum velocity. So increase in the Vmax. First remove this increase in the Vmax. Okay. Now you left with the two options. Constant Km and decrease Vmax, decrease Km and decrease Vmax. Okay. So non-competitive inhibition, there is Km remain constant, and Vmax decreases. Km remain constant and Vmax decreases. So here answer is constant Km and decrease Vmax. Now see the graphs. So this is second. Km increases but Vmax remains same in which type of inhibition? Answer this. Yes. Km increases, it is competitive inhibition. See the graph. This is very, very important. It can be a image based question. It can be a image based question. Don't think too much in this. This is a line viewer Burke plot. So if it is X shape, this is X shape. If it is X shape, it is competitive inhibition. If it is X shape, it is competitive inhibition. If it is V shaped, it is non-competitive inhibition. And if they are parallel lines, it is the uncompetitive inhibition. So in competitive inhibition, line viewer Burke plot is the X shape. So here the Km increases and Vmax remain same. Km increases and Vmax remains same. What is Km? What is Km? It is substrate concentration to produce half of the maximum velocity. Km means substrate concentration to produce half of the maximum velocity. Okay. So here, what is the sense in making such type of graph? What is the sense? Don't you can draw the simple graph here. Okay. So this is the without inhibitor. This is with inhibitor. But what is need of drawing this line viewer Burke plot? So it has one important advantage. Okay. It has one important advantage. What is that? So you can calculate the Km and Vmax at lower substrate concentration. It is every time it is not possible to achieve this saturation level. Every time in the practical setup, every time it is not possible to achieve this the saturation level. You can draw the graph at the minimum concentration of the substrate, means at the lower concentration of substrate. So it is useful. That's why it is used. Line viewer Burke plot. Okay. So in competitive inhibition, it is X-shaped graph. In non-competitive inhibition, it is V-shaped. There is no competition between substrate and inhibitor. Inhibitor does not bind to the active site of an enzyme. It binds to the site other than active site of an enzyme. And most of the time, non-competitive inhibition is irreversible. Most of the time, the most common example is enolase. Enolase inhibit the enzyme of glycolysis. The fluoride ions inhibit the enzymes of glycolysis, that is enolase, which is used for the collection of the blood sample. So non-competitive inhibition, it is the V-shaped graph. And this is uncompetitive inhibition, parallel lines. So image based question, you can get image based question. Okay. Now the competitive inhibition therapeutic uses. These are very, very important questions. Urea. It does not require to reach Vmax for getting Km. The substrate, it is, yes, correct. So it is every time not possible to achieve the higher substrate concentration or plateau level. Substrate saturation or plateau level. It is not possible. So line viewer Burke plot is very, very important. So that's why the complicated, it seems complicated, but it has advantage. Okay. In the given diagram, identify the drug Z marked by the arrow. Identify the Z. Drug acting on this enzyme, vitamin K reductase, vitamin K epoxide reductase. Yes? Answer this question. Which of the following act on this? This is pharmacology. This is pharmacology question connected with biochemistry. The dicumarol and warfarin is the answer. Dicumarol and warfarin. If warfarin is also correct option, if warfarin is there. Okay. So they inhibit the vitamin K epoxide reductase. These are the oral anticoagulant. Oral anticoagulant. What are the functions of vitamin K and what are the different forms of the vitamin K? Vitamin K has three different forms: K1, K2 and K3. K1, K2 and K3. K1 is phylloquinone. C option, dicumarol. Yes, correct. K1 is the phylloquinone, this is menaquinone and this is menadione. Menadione. It is water soluble. All of you know that vitamin K is the fat soluble vitamin, but this synthetic form is the water soluble, and 1 milligram of menadione, it is given at the birth intramuscularly. Intramuscular injection of menadione is given at birth prophylactically to prevent the bleeding. It is given to prevent the bleeding prophylactically. 1 milligram of menadione. It is water soluble. These are the fat soluble vitamins. K2 is phylloquinone. This is menaquinone. And this is menadione. K2, it is produced by the intestinal bacteria. It is present in food of animal origin. This is present in green leafy vegetable, particularly spinach. This is the endogenously produced vitamin K2. What are the other endogenously produced vitamins? It includes the niacin, which is produced from the thiamine. Then after niacin, the biotin is there. Then vitamin D, pantothenic acid, and one left, that is K2. These are the endogenously synthesized or endogenously produced vitamins. Now, what is function of vitamin K? It is required for the post-translational power player. Hello, power player. So, it is required for vitamin K. It is required for gamma carboxylation. It converts the glutamate. This is glutamate, NHCH3OOCH2. This is COOH. This is glutamate in the clotting factor 2, 7, 9, 10. This the alpha, beta, gamma. So this gamma carbon, it is connected to OO. Okay. So it is connected to carboxyl group. This is known as gamma carboxylation. It is post-translational modification of clotting factor 2, 7, 9, 10. Then protein C, protein S, then osteocalcin, and matrix GLA protein. These are the different proteins which are activated by the post-translational modification, that is gamma carboxylation. Okay, so these are important. Vitamin K action. Okay. Lovastatin, group of drug. Lovastatin, simvastatin, atorvastatin. These are the group of drugs which are prescribed to the patient with coronary artery diseases. You check the medicine. If you have the old member in the family, check the prescription of your dadaji or nanaji, whatever, whichever it may be. You can found some drugs, that is statins. These are to lower the cholesterol level. These drugs are given to lower the cholesterol level. It acts on the enzyme. What is the answer here? The answer is HMG coenzyme A reductase. So this is the cholesterol pathway in which the precursor molecule is acetyl coenzyme A. You know the cholesterol, it has 27 carbon, 1 hydroxyl group at 3 prime, 5 prime, 6 prime, double bond between the 5 prime and 6 prime carbon. Then it contains cyclopentanoperhydrophenanthrin ring. Animal sterol with cyclopentanoperhydrophenanthrin ring, hydroxyl group at 3 prime position, double bond between the 5th and 6th position, having the 27th carbon. And it is a precursor. Cholesterol, it is a precursor for vitamin D, bile acids, and steroids, glucocorticoids, mineralocorticoid, and sex steroids. Okay, it is a precursor for these three. It is synthesized from acetyl coenzyme A. 2 molecules of acetyl coenzyme A form acetoacetyl coenzyme A, and acetoacetyl coenzyme A, acetoacetyl coenzyme A again condenses with acetyl coenzyme A. to form HMG, hydroxymethyl glutaryl coenzyme A, which is converted into mevalonate, and through various steps it is converted into cholesterol. Okay. So this step it is catalyzed by HMG coenzyme A reductase. This is the rate limiting step in the cholesterol synthesis. Okay, it requires NADPH. NADPH is required for the reductive biosynthesis. And what are the sources of NADPH? Three important sources for the NADPH. Three important sources. Sources of NADPH. First source is the HMP shunt. Two important enzymes in the HMP shunt. One is the glucose 6-phosphate dehydrogenase and phosphogluconate dehydrogenase. Second is the malic enzyme. That is NADP malate dehydrogenase, malic enzyme. And third important source is cytosolic isocitrate dehydrogenase. These are the these three are the important source of NADPH. HMP shunt provides 60% NADPH. It provides 60% NADPH. So this HMG-CoA reductase inhibit the lovastatin inhibit the HMG-CoA reductase, which is structurally, this lovastatin, it is structurally similar to that of hydroxymethyl glutaryl coenzyme A. This is the substrate for this HMG-CoA reductase. So they are analog. They are substrate analog to each other. They are similar in structure to each other. So they compete with the active site of an enzyme. Sodium fluoride present in the fluoride bulb is an inhibitor of, sodium fluoride is an inhibitor of, it is inhibitor of enolase enzyme. It is inhibitor of enolase enzyme. Okay. So what is the use of sodium fluoride? See. So this is a bulb. You can get a image based question if it is a gray top tube. It is known as sodium fluoride bulb. The composition of sodium fluoride is the sodium fluoride and potassium oxalate. Sodium fluoride and potassium oxalate in the ratio of 1:3. And this is used, this bulb or this tube, gray top tube, it is known as fluoride bulb. It is used for collection of blood sample for glucose estimation, or plasma glucose estimation. If we do not collect the sample in fluoride bulb, the sugar level will drop down by 5 to 10 milligram per deciliter per hour. To avoid this, that we use the sodium fluoride as an inhibitor of enolase. So it inhibits the step, that is the phosphoglycerate, 2-phosphoglycerate is converted into phosphoenol pyruvate through this enolase, and this reaction is blocked. It is a non-competitive inhibitor, irreversible inhibitor of enolase enzyme, inhibit the glycolysis, maintain the sugar level in the collected sample for the up to its estimation. For the prolonged time, it maintain the blood glucose level. That's why it is important. So this is a fluoride bulb. This is red top tube. It is a plain bulb without any additive. It is used for the collection, and it is a principal tube used in biochemistry. It is for the estimation of urea, creatinine, SGOT, SGPT, then total protein, albumin, cholesterol. Many parameters can be done in the serum obtained from this red tube. And this is EDTA bulb. This is plain bulb. This is EDTA bulb. It is mainly used for the complete blood count. It is in the pathology. Okay. The rate limiting enzyme of glycolysis is, which one is the rate limiting enzyme? So it is the phosphofructokinase, which is a rate limiting enzyme in the glycolysis. It is important. What are the different features of glycolysis? It occurs aerobically, anaerobically. The energy produced via the anaerobic glycolysis, the energy production is 2 ATPs are produced, while aerobic glycolysis, there are production of 7 ATPs. There are production of 7 ATP. So it is important because when the oxygen is lacking, this pathway is operative. Okay. So wrap up. So glycolysis is important pathway. There are 3 irreversible steps in the glycolysis. One is conversion of glucose to glucose 6-phosphate. Second reaction is conversion of fructose 6-phosphate into fructose 1,6-bisphosphate. And third important reaction is phosphoenol pyruvate is converted into pyruvate. These are the irreversible steps in the glycolysis. These are the 3 irreversible steps in the glycolysis. This step is catalyzed by the glucokinase or hexokinase. This is catalyzed by the phosphofructokinase, and this step is catalyzed by the pyruvate kinase. These are the 3 important enzymes of the glycolysis. Okay. So do you know the difference between glucokinase and hexokinase? Glucokinase, it is present only in the liver, and it is inducible enzyme via the glucagon. It acts only on the glucose. It acts only on the glucose, and it acts when the glucose concentration is more than 100 milligram per deciliter. Glucokinase will act. It acts on the well-fed state, and it is important for the glycogenesis. This will divert the glucose. Mainly glucokinase, it is important. So glucokinase, it is important. It is well-fed state, induced by the glucagon. So wait here. It is inducible enzyme, glucokinase. Okay. While hexokinase, it is not inducible enzyme. Okay. It is present in all cells of the body. It is active against the hexoses, all hexoses. So this is the first important. This is the rate limiting step, phosphofructokinase. It is inhibited by the citrate and ATPs. Citrate and inhibited by the ATP. So this is important. Remember this citrate, because citrate is the activator of acetyl coenzyme A carboxylase. Okay. So it is inhibitor of phosphofructokinase. The phosphofructokinase, it is activated by this fructose 6-phosphate, and fructose 6-phosphate is converted into fructose 2,6-bisphosphate. This will also activate this. Okay. It is by the phosphofructokinase 2. So fructose 6-phosphate and fructose 2,6-bisphosphate will activate the phosphofructokinase. These hormones are under the influence of glucagon and insulin. Insulin favor the glycolysis, utilization of glucose. Okay. Now what are the rate limiting enzymes of different pathways, and what are the energetics? We'll discuss the energetics and rate limiting enzymes. So wait. So first we'll discuss the energetic. So glycolysis will give you how many ATP? Glycolysis, 2 types. Anaerobic glycolysis will give you how many ATP? Just think in your mind. Okay, anaerobic glycolysis will give you how many ATP? Or in the write down in the comment box. Aerobic glycolysis will give you how many ATP? Pyruvate dehydrogenase complex will give you how many ATP? Then TCA cycle will give you how many ATPs? Okay. Then RL cycle, Rappaport-Lubering cycle gives you how many ATPs? Then beta oxidation of palmitic acid. Then stearic acid. This is important. So how many ATPs are given? Yes, 2, 7. I will link that. Okay. So anaerobic glycolysis will give you 2 ATPs. Okay. Aerobic glycolysis will give you 7 ATPs. Pyruvate dehydrogenase complex, single molecule of pyruvate will give you how many ATP? Single molecule. Okay, single molecule will give you 2.5 ATP. But in glycolysis, there is production of 2 molecules of pyruvate. So into 2, so it will give you 5 ATPs. Then TCA cycle per turn, single turn of TCA cycle will give you how many ATPs? It will give 10 ATPs. But there is production of 2 molecules of acetyl-CoA. So 10 plus 10, it is 20 ATPs. So how many ATPs are produced by the oxidation of glucose molecule? Calculate it. Oxidation of glucose molecule. So 7 plus 5 plus 10 plus 10. Total 32 ATPs are given by the oxidation of glucose. Yes, TCA cycle Moria, TCA cycle will give you 10 ATPs. Rappaport-Lubering cycle will give you how many ATPs? And HMP shunt will give you how many ATP? 0. They will give you 0 ATPs. Beta oxidation of palmitic acid, yes. Beta oxidation of palmitic acid. It will give you 106 ATPs. And the stearic acid, this is 16 carbon compound. This is 18 carbon compound. It will give you 120 ATP. So this is energetics. Okay. So what is the rate limiting enzyme in the glycolysis? The rate limiting enzyme in the glycolysis, it is glycolysis, rate limiting enzyme is phosphofructokinase. Phosphofructokinase. Then fatty acid synthesis, which one is the rate limiting enzyme? Synthesis. Which one is the rate limiting enzyme? Acetyl coenzyme A carboxylase. Carboxylase. It is also multifunctional enzyme. Fatty acid synthase is a multifunctional enzyme, but this is also multifunctional enzyme. It is composed of 2 enzymes. One biotin carrier molecule and biotin, that is acetyl coenzyme A carboxylase. Beta oxidation, which one is the regulatory step? It is carnitine acyl transferase. Carnitine acyl transferase, it is a regulatory step in the beta oxidation. Then the cholesterol synthesis, which one is the regulatory enzyme? Cholesterol synthesis, it is HMG coenzyme A reductase. And ketogenesis, which one is the regulatory enzyme? Ketogenesis, HMG CoA synthase. HMG coenzyme A synthase. Which enzyme is absent in the liver? That's why liver cannot utilize this ketone body. It is thiophorase, which is absent in the liver. That's why liver can't utilize the ketone bodies. Okay. The TCA cycle, it is mainly isocitrate dehydrogenase, but it is mainly dependent on the availability of the substrate. TCA cycle, availability of the citrate. Pyruvate dehydrogenase itself is the regulatory enzyme. Pyruvate dehydrogenase complex. The HMP shunt, important enzyme is HMP shunt. Important enzyme is glucose 6-phosphate dehydrogenase. Then the glycogenesis, it is synthase, glycogen synthase. And glycogenolysis, it is glycogenolysis means breakdown. It is glycogen phosphorylase. These are the important key enzymes in the different pathways. And this is energetics, which is important. So this is important. Okay. 2,3-BPG is synthesized in which of the following pathway? It is synthesized in the alternative pathway of the glycolysis, that is Rappaport-Lubering cycle. In the glycolysis, there is production of glyceraldehyde 3-phosphate, 3-phosphate. This glyceraldehyde 3-phosphate is converted into 2,3-bisphosphoglycerate. 2,3-bisphospho. It is converted into 1,3-bisphosphoglycerate. This 1,3-bisphosphoglycerate by the mutase reaction. By the mutase reaction, it is converted into 2,3-bisphosphoglycerate. And by the phosphatase, it is again converted into phosphoglycerate, 3-phosphoglycerate. And then it is through various steps, it is converted into pyruvate. So this is alternative pathway for oxidation of glucose, Rappaport-Lubering cycle, in which 1,3-bisphosphoglycerate is converted into 2,3-bisphosphoglycerate, and this has important use in our body. It is negative effector. It decreases the binding of O2 to hemoglobin. It occupies the central pocket in the hemoglobin molecule. It particularly attached to the, this is negatively charged, 2,3-bisphosphoglycerate. It is negatively charged molecule. It attached to the positively charged lysine arginine of beta chain of that globulin, beta globulins. It attached to the beta chain of hemoglobin molecule by negative positive charges, and it causes unloading of oxygen to the tissue. It is very, very important for unloading of oxygen to the tissue. It is important in anemia. It is important in anemia. It is important in high altitude hypoxia. Hypoxia. It is important. It is important in fetal hemoglobin. And it is important in chronic obstructive pulmonary disorders. There is increased level of 2,3-BPG, and that causes the unloading of oxygen to the tissue. That's why it is important. So this is the oxygen saturation curve. So 2,3-BPG shift the oxygen dissociation curve to the right. It shift the oxygen dissociation curve to the right. It shift the curve to the right. Okay, it is a negative effector. Along with the 2,3-BPG, the other molecules are there. Increase in H ion concentration, that is decrease in the pH, CO2, 2,3-BPG, and increase in the temperature. These are the negative effector. They shift the oxygen dissociation curve to the right. Okay. This multi-enzyme complex converts pyruvate to acetyl coenzyme A and identify E1 and E2. Identify the E1 and E2. So this is the multi-enzyme complex composed of 3 enzymes and 5 coenzyme. What is the answer here? Try to recollect what is the answer here. So here answer is pyruvate dehydrogenase and dihydrolipoyl transacetylase. It is composed of 3 enzymes. See, this is pyruvate. Wait. Okay. So this is pyruvate. It is converted into CO2. So this is oxidative decarboxylation reaction. Here, thiamine pyrophosphate, it is converted into hydroxyethyl thiamine pyrophosphate. Thiamine pyrophosphate, it is converted into hydroxyethyl thiamine pyrophosphate. Here E1 is required. E1, this is E1. E1 is pyruvate dehydrogenase itself. E1 is pyruvate dehydrogenase itself. Now in this reaction, then it is transferred, this hydroxyethyl group transferred to lipomide, and lipomide, this is the lipomide. It is converted into acetyl lipomide. Acetyl lipomide. And in this reaction, coenzyme A, it is converted into acetyl coenzyme A. Coenzyme A is converted into acetyl coenzyme A. So there is formation of oxidized lipomide. Okay. Now this is with the help of NAD and FAD. NAD and FAD. This is third enzyme. This is E2. That is dihydrolipoyl dihydrolipoyl transacetylase. And this is E3. It is dihydrolipoyl dehydrogenase. So these are the three enzymes, E1, E2, E3. What are the 5 coenzymes required for this reaction? See the 5 coenzymes. One is thiamine pyrophosphate. Second one is the lipomide. Third one is the coenzyme A, FAD, NAD. 4, 5th. These are the 5 coenzymes required. 3 enzymes: pyruvate dehydrogenase, dihydrolipoyl transacetylase, dihydrolipoyl dehydrogenase. Okay. What are the similar enzymes? Similar enzymes includes the 2 more. It is alpha keto glutarate dehydrogenase and branch chain keto acid dehydrogenase. These are the 2 more enzymes which is similar to that of pyruvate dehydrogenase complex. And how it is regulated? Remember the 4 names, at least 4 names you should remember. The enzymes which are active in the dephosphorylated state. Enzymes active in dephosphorylated states. Okay, that includes glycogen synthase, then HMG coenzyme A reductase, then third one is acetyl coenzyme A carboxylase, and fourth one is the pyruvate dehydrogenase. These are the 4 important enzymes which are active in the, these are the enzymes which are active in the dephosphorylated state. Adhikari, anyone from AIIMS Bhubaneswar. So enzymes that are active in the dephosphorylated state: glycogen synthase, HMG co-reductase, acetyl coenzyme carboxylase, and pyruvate dehydrogenase. These are the important enzymes, these 4. These are rate limiting enzymes. How they are rate limiting enzymes? Glycogen synthase, glycogenesis, HMG co-reductase, cholesterol biosynthesis, acetyl coenzyme carboxylase. This is important in the fatty acid synthesis. Pyruvate dehydrogenase complex in the linked reaction. Okay, how they are regulated? By phosphorylation and dephosphorylation. So how dephosphorylated state is maintained? It is mainly favored by the insulin. How dephosphorylated state is maintained? It is favored by the insulin. Okay, so this is how the PDH complex work. PDH complex. Now amino acid linking the Krebs cycle and urea cycle. See, amino acid which linking the Krebs cycle and urea cycle. So answer here is aspartate. Aspartate is the answer. This is the second link in between these 2 cycles. Now see, that's why it is known as Krebs bicycle. One wheel is urea cycle, the another wheel is Krebs cycle. So how it is connected? See, oxaloacetate, it is converted into aspartate by the transamination reaction. Pyridoxal phosphate is required for the transamination reaction. It is converted into aspartate. Aspartate enters the urea cycle. And here is liberation of fumarate which enters the TCA cycle. This is how these cycles are connected. Via the aspartate, via the fumarate. Now, CO2 which is produced in the TCA cycle, it is utilized here in the urea cycle. CO2 which is produced in the TCA cycle, it is utilized in the urea cycle. Okay. Then next one is the ATP. So NADH will give 2.5 ATP. This will give 2.5 ATP. So this will give FADH to give 1.5 ATP. NADH will give 2.5 ATP. So ATPs are produced in the TCA cycle and 4 ATPs are utilized. So net ATP utilization is 1.5 ATP because it gives the fumarate and fumarate will give the malate and this is NADH. So 1.5 ATP because fumarate will give the 2.5 ATP. So it is net consumption is 1.5 ATP. Okay, so this is how these two pathways are connected to each other. So TCA cycle, it is very, very important. First two enzymes, these are the mitochondrial enzymes, while those whose name starts with the A in the urea cycle, they are cytosolic enzymes. Okay, they are cytosolic enzymes. Question number 22, ammonia causes depletion of which of the following in the TCA cycle? Ammonia. So ammonia combines with the alpha ketoglutarate. Your answer is alpha ketoglutarate. Okay, so alpha ketoglutarate combines with ammonia to form glutamate. Glutamate again combined with the ammonia to form glutamine. Glutamine is the transport form of ammonia from the brain and intestine, while from the muscle it is in the form of alanine. So it depletes the alpha ketoglutarate level. So decrease in the alpha ketoglutarate level decreases the ATP synthesis and causes toxic effect. So NH3 is toxic, ammonia is toxic to the brain because it depletes the alpha ketoglutarate level, which is important for the ATP synthesis. So that's why ammonia is toxic to the brain. Okay. So this is urea cycle. There are 5 enzymes in the urea cycle. See, carbamyl phosphate synthetase 1, this is the first. Then ornithine transcarbamylase, this is second. Arginosuccinate synthetase, it is third. Arginosuccinate lyase, it is fourth. And arginase fifth. 5 enzymes. The defect in 5 enzyme causes the 5 disorders. That is known as the urea cycle disorders. This enzyme, it is particularly present in liver. Arginase, it is particularly present in liver, and that's why the urea cycle or ornithine cycle or Krebs-Henseleit cycle, it occurs in the liver because arginase is present in the liver. Now defect in these 5 enzymes lead to the 5 different urea cycle disorder. So this is hyperammonemia type 1, in which NH3 level increases and they are toxic. These first 2 disorders are very, very toxic because there is increase in the ammonia level. Okay, ornithine transcarbamylase, there is increase in the NH3 level. There is also increase in the orotic acid. Orotic acid. Why orotic acid level increases? Because block in this pathway accumulates the carbamyl phosphate and it will divert it for the pyrimidine metabolism, pyrimidine synthesis. Pyrimidine synthesis. Okay. So NH3 and orotic acid accumulates in the ornithine transcarbamylase defect, that is the hyperammonemia type 2. Then arginosuccinate synthetase defect, that is citrullinemia. In the citrullinemia, citrulline will elevated levels of citrulline. Then arginosuccinate lyase deficiency causes arginosuccinate aciduria. And one another feature is associated with this disorder, that is trichorexis nodosa. Trichorexis nodosa. That is tufted hair, brittle hair, and that is known as trichorexis nodosa in the arginosuccinic aciduria. And hyperargininemia, there is increase in the arginine level. So arginine level increases. Here arginosuccinic acid increases. Here citrulline increases. So 1, 2, 3, 4, 5. And one disorder is there, that is known as triple H syndrome, HHH syndrome, because of defect in ORNT1 gene. Triple H syndrome, defect in or mutation in ORNT1 gene, that is ornithine transporter 1 gene, which is important for transfer of ornithine from cytosol to mitochondria. So defect causes the triple H syndrome, that is hyperammonemia, hyperornithinemia, and homocitrullinuria. hyperammonemia, hyperornithinemia, and homocitrullinemia and urea. Homocitrulline accumulation and excretion in urine. So these are the 3H, triple H syndrome due to mutation in ORNT1 gene. See, type 1, type 2, it is X-linked, type 2 is X-linked. This is due to carbamyl phosphate synthetase 1 defect, ammonia accumulated. Type 2, ornithine transcarbamylase defect, there is accumulation of ammonia and orotic acid. Citrullinemia, arginosuccinate synthetase defect, accumulation of citrulline. Arginosuccinic aciduria, arginosuccinate lyase defect, arginosuccinate, and the tufted hair, brittle hair, that is known as Trichorexis nodosa. Okay, and argininemia or hyperargininemia, there is increase in the arginine level. Now question number 23. A 9-month-old infant developed poor feeding, hepatosplenomegaly and convulsion. He has dry and brittle hair. On examination, blood shows increased level of, this is a hint, arginosuccinic acid and ammonia. If there is arginosuccinic acid and ammonia excretion, it is urea cycle defect. Oh, these are all urea cycle defect now. Now identify. Just try to identify. Just try to identify in your mind. If you are not writing it in the comment box, just try to identify in your mind. So here answer is arginosuccinic acid urea. Why arginosuccinic acid urea? Because arginosuccinic acid increases, there is ammonia level increases, there is Trichorexis nodosa. Okay, so it is urea cycle disorder. The family consuming predominantly polished rice. Now we are shifting. Okay, so pyruvate dehydrogenase complex, then the alpha ketoglutarate dehydrogenase complex, branch chain keto acid dehydrogenase complex, and the coenzymes related with this complex, that is thiamine pyrophosphate. Again, an important top rated question for any examination, whether FMGE, whether INICET, or whether it is the PG entrance examination. I already told you that there were 5 questions on single topic, but from the different subject. Vitamin is related with biochemistry. Vitamin, minerals, they are related with biochemistry, they are related with pediatric, they are related with medicine, they are related with community medicine. Okay, that's why these topics are very, very important. Okay, so the family consuming predominantly polished rice as a staple diet, which vitamin is deficient? Okay, polished rice. So your answer is thiamine. Thiamine, it is present, 80% of thiamine activity, it is present in outer alluron layer of whole grain, outer alluron layer of whole grains. Thiamine, it is present in outer alluron layer of whole grains. Okay, so it is present when we do the polishing to make it smart, when we polish the rice to make the rice smart. Okay, so more white, we are moving toward the whites. Polishing means we are moving to the white and white rice. So 80% of thiamine, it is removed by polishing in the mill. The polishing is done in the mill, rice mill. Okay, so 80% is removed, and when the polished rice, we consume the polished rice as a staple diet, it causes the deficiency of thiamine. Okay, it causes the deficiency of thiamine. Now thiamine, we will discuss the thiamine. This is very, very important, thiamine. So thiamine, the coenzyme form is thiamine pyrophosphate. It is important reaction, 2 important reaction. One is oxidative decarboxylation. And second important reaction is transketolase reaction of HMP shunt. Ketolase reaction of HMP shunt. These are the 2 important reactions catalyzed by the thiamine pyrophosphate. So blood levels for the deficiency status of thiamine, it is known by the blood level of RBC transketolase activity. RBC transketolase activity. Okay. Now, if there is deficiency of thiamine, the requirement is 1 to 1.5 milligram per day. Now, the thiamine, wait. So if there is deficiency of thiamine, when we consume polished rice as a staple diet, there is deficiency of thiamine, and thiamine deficiency causes the beriberi. Beriberi means weakness. Beriberi means weakness. So it can be dry beriberi, it can be wet beriberi, or it can be infantile beriberi. Also in severe stages or when it is fulminant, it is known as the Soshin beriberi. Okay, and if there is deficiency of thiamine, pyrophosphate, in alcoholic, it lead to the disorder that is known as Wernicke's Korsakoff syndrome. Wernicke's-Korsakoff syndrome. Now this dry beriberi means neuritis, peripheral neuropathy. So neuropathy will be there. Okay. Wet beriberi means severe manifestations, effusions, accumulation of fluid in pleural cavity, pericardial cavity, abdominal cavity. There is high output cardiac failure. High output cardiac failure. There is high BP, blood pressure. Infantile, it is with the severe manifestations. Okay. So dry beriberi, it causes the neuropathy. Wet beriberi, severe manifestations, accumulation of fluids in the cavity, pleural cavity, pericardial cavity. There may be ascites. So high output cardiac failure, increase in the BP, that is wet beriberi manifestations. Infantile beriberi, severe involvement, it involves the infant. In chronic alcoholic, there is decrease in the absorption of thiamine pyrophosphate from the intestine. There is decrease in the absorption and decreased conversion of thiamine to thiamine pyrophosphate. Because of chronic alcohol consumption, there is decreased conversion of thiamine to thiamine pyrophosphate. And what are the symptoms of Wernicke's-Korsakoff syndrome? You must have made a plan for the Goa trip. Okay, so Goa, it is in everyone's mind. है ना? So Goa MP is the mnemonic. Goa MP. So Wernicke's encephalopathy, the symptoms are Goa, and Korsakoff psychosis, the symptoms are MP. Goa MP. Now what are the symptoms? So it is global confusion. Then ophthalmoplegia. Paralysis of ocular muscle. Ataxia. Gait disturbances. Memory loss. And psychosis. These are the symptoms of Wernicke's-Korsakoff syndrome. Of these, Goa, global confusion, ophthalmoplegia, ataxia, these are the symptoms of Wernicke's, encephalopathy, and memory loss and psychosis. These are the symptoms of Korsakoff syndrome. Okay. So next, a patient presented with pleural effusion. Bilateral crepitations were felt in the lungs. A diagnosis of congestive high output cardiac failure was made. High output cardiac failure. This is a case of wet beriberi. Which vitamin is deficient? The vitamin B1, thiamine, is deficient. A chronic alcoholic was brought to the hospital with symptoms of confusion, ataxia, and sixth nerve palsy. What is your diagnosis? See, confusion, ataxia, and sixth nerve palsy. So these are the symptoms of, see the options. Barlow's disease is the infantile scurvy, And acrodermatitis enteropathica, it is dermatitis because of zinc deficiency. This is scurvy. Scurvy. Now Wernicke's or Korsakoff. So is there memory loss or psychosis? There is no memory loss and there is no psychosis. So it is a case of Wernicke's encephalopathy. Now the next question. So we'll wait for the 2 minutes and then again we will continue. So just wait for the 2 minutes. I have to drink the water. Just try to solve this question. I will be back in 1 minute. So hello everyone. Now try to solve this question. 28 days old infant was brought to the hospital. With poor feeding, convulsions and vomiting. So brought to the hospital 28 days old with poor feeding, convulsions and vomiting. Urine had smell of burnt sugar. Biochemical analysis suggestive of increased branch chain amino acid and their keto acids in the urine. Increased branch chain amino acid and their keto acids in the urine. ABG shows low bicarbonate level. What is your probable diagnosis? So, maple syrup urine disease, smell of burnt sugar. Yes, correct. PKU, no mousy odor of urine, no hypopigmentation, no mental retardation. Homocystinuria, we already discussed the homocystinuria, subluxation of lens, CVS anomaly, then mental retardation. Alkaptonuria, black urine. Okay, so here answer is maple syrup urine disorder. It is maple syrup urine disorder. Is everything is okay? I am audible and visible to you. Please give me a thumbs up if I am audible and visible to you. Okay, so maple syrup urine disease is the answer here. See, this is a disorder of branch chain amino acid, valine, leucine and isoleucine. Valine, leucine and isoleucine. It is very easy to remember branch chain amino acid, VIL, valine, leucine and isoleucine. This amino acid, branch chain amino acid, by the transamination reaction, they are converted into alpha keto acids. They are converted into alpha keto acids. And this alpha keto acid by alpha keto acid dehydrogenase, means branch chain alpha keto acid dehydrogenase, it is converted into acyl coenzyme A, respective acyl coenzyme A. And then they will give you, the valine will give you glucose. The leucine will give you the fat. It will give you acetoacetate. Isoleucine will give you both glucose and fat. So that's why it is known as both glucogenic and ketogenic amino acid. Isoleucine. All three aromatic amino acid, phenylalanine, tyrosine, tryptophan and isoleucine will give you glucose and fat. Okay, leucine is the exclusively ketogenic amino acid. So this is the alpha keto acid dehydrogenase. It is an important enzyme. If it is blocked, it is lead to the disorder that is known as maple syrup urine disease, classical maple syrup urine disease. And if it is defective, there is excretion of these alpha keto acids in the urine, excretion of these amino acids in the urine. If there is excretion of keto acid in urine, it will give the Rothera's test positive. This branch chain keto acid in urine will give the Rothera's test positive. And the bicarbonate, it is utilized for neutralization of this acid, for buffering these acids. So there is decrease in the bicarbonate level. It is a severe disorder. It is a fatal disorder. Thank you, Ashutosh. It is a severe and fatal disorder because it lead to the neurological involvement. Then there is floppy infant. There is alternate episodes of hypotonia and hypertonia. So that gives the boxing like appearance of the child. Okay, neurological involvement, floppy infant. Then smell of burnt sugar. That's why the name is given maple syrup urine disorder. Okay, maple syrup urine disorder. The enzyme which is deficient is branch chain alpha keto acid dehydrogenase. It is 3 enzyme and 5 coenzyme, like pyruvate dehydrogenase complex, 5 coenzyme. But here the first enzyme is not branch chain keto acid dehydrogenase. The first one is the branch chain keto acid decarboxylase is the first enzyme. Okay, so this is the maple syrup urine disease. Black urine in infancy. This is very important question. It seems easy, but it is very important. Black urine in infancy on standing means urine turns dark on standing. It is a typical feature of which disorder? Answer is alkaptonuria. Okay. PKU, what is the characteristic of PKU? The mousy odor of urine because of excretion of phenyl acetate and phenylacetyl glutamine, mainly the phenyl acetate and its byproducts. Then maple syrup urine disease, it is burnt sugar, smell like burnt sugar. Okay, homocystinuria. So in homocystinuria, the cyanide nitroprusside test is positive. Alkaptonuria, it is black urine on standing. Black urine on standing. On exposure to air, on oxidation, on exposure to air, it is converted into black pigment that gives the black color to the urine. Okay. Now see, this is phenylalanine. All of you know that phenylalanine is converted into tyrosine. Phenylalanine is converted into tyrosine. What is another name of tyrosine? Para-hydroxyphenylalanine. This tyrosine undergoes transamination. By the transaminase, this tyrosine is converted into keto acid. So this is para-hydroxyphenylalanine. It is converted into para-hydroxyphenylpyruvate. Alanine is converted into pyruvate, para-hydroxyphenylpyruvate. So by the hydroxylase, this para-hydroxyphenylpyruvate, by the para-hydroxyphenylpyruvate hydroxylase, it is converted into dihydroxy phenylacetate. Another name is homogentisate. This is the common name, homogentisate. Okay. Then homogentisate oxidase, it is converted into 4-mallyl acetoacetate. And this mallyl acetoacetate is converted into fumaryl acetoacetate, which is converted into fumarate acetate, is converted into fumarate and acetoacetate. So in this way, this will give you glucose and fat. This aromatic amino acid will give you glucose and fat. So phenylalanine is converted into tyrosine. Tyrosine will give you the para-hydroxy phenyl pyruvate. By the transamination reaction, this is converted into dihydroxy phenyl acetate or homogentisate, which is converted into 4-mallyl acetoacetate and 4-fumaryl acetoacetate by the isomerase. And by the hydrolase, this is converted into 2, that is fumarate and acetoacetate. So acetoacetate. So acetoacetate. Okay, is converted into fumarate and acetoacetate. That will give you glucose and fat. That's why these aromatic amino acids are glucogenic and ketogenic. Now see, the block in this tyrosine transaminase, lead to the tyrosinemia type 2. Para-hydroxy phenyl pyruvate hydroxylase, it lead to the neonatal tyrosinemia. Then homogentisate oxidase defect, alkaptonuria, black urine. This isomerase and hydrolase defect, it lead to the disorder that is tyrosinemia type 1. And defect in this phenylalanine hydroxylase. This is important enzyme. The defect, it causes phenylketonuria. We are in the discussion of alkaptonuria. Now we will focus on alkaptonuria. So if there is defect in homogentisate oxidase, this homogentisate is converted into benzoquinone acetate. Benzoquinone acetate, which on polymerization will give the alkaptone. And this is a pigment, black pigment, which is deposited into the tissues, various tissues, and chronic deposition causes the arthritis. This disease is mild in the childhood, but it develops into chronic arthritis in the adulthood, deposition of alkaptone, and it gives black color to the cartilage, bone, nose cartilage, etc. A patient came to hospital with complaint of abdominal pain. Routine investigation were unremarkable. On observation, the urine turned black on standing. Which of the following enzyme is likely to be defective in this patient? Urine turned dark on standing. So it is a case of alkaptonuria. What is diagnosis here? Alkaptonuria. And which one is defective? See which one is defective. See for the other options also. So this is alkaptonuria. Xanthine oxidase, this is xanthine acid urea. Okay. Then phenylalanine hydroxylase, phenylketonuria. Dihydroorotate dehydrogenase, nothing is related with this. Xanthine oxidase, xanthine urea, which is characterized by decreased uric acid level. Okay. So here diagnosis is alkaptonuria. Okay. Because of polymerization of benzoquinone acetate, it is converted into homogentisate oxidase. Very good, Raj. Homogentisate oxidase defect. A 25-year-old patient presented with dark urine which further blackens on exposure to air. What the enzyme defect in this case? That's why we discussed the two names. Okay, what's the defect? See, tyrosine is converted into tyrosine. Another name is para-hydroxy phenylalanine. Tyrosine is converted into, by transamination, para-hydroxy phenyl pyruvate, and this para-hydroxy phenyl pyruvate, it is converted into dihydroxy phenyl acetate, and this is dihydroxy phenyl acetate is converted into 4-mallyl acetoacetate. So this is homogentisate, and dihydroxy phenyl acetate dioxygenase or homogentisate oxidase. So see for the option. So fumaryl acetoacetate deficiency, fumaryl acetoacetate hydrolase will causes the tyrosinemia type 1. Then homogenticate dehydrogenase, nothing is related. Phenylalanine is hydroxylase, it is phenyl ketone urea. Now dihydroxyphenyl acetate dioxygenase. The another name is homogenticate oxidase. Another name of this enzyme is homogenticate oxidase. Oxidase. Okay. A baby boy, 10-month-old, comes with vomiting, jaundice, hepatomegaly, and signs of irritability when started weaning with fruit juice. Which of the following is defective? So there is lot of confusion between the hereditary fructose intolerance and the galactosemia. There is confusion between hereditary fructose intolerance and galactosemia. So if the symptoms are developed from the birth due to the breastfeeding, not the abdominal symptoms, the rest of the symptoms. Sir, I am below average student. How to crack NEET UG? This is not for NEET UG. Okay. So see, so galactosemia and the hereditary fructose intolerance, these are the two conditions. Okay. In hereditary fructose intolerance, conditions worsen on taking the food which is rich in the fructose. In galactosemia, as infant is already on the breast milk, the symptoms are gradually developed. Okay, while in the lactose intolerance, there is the symptoms like bloating, diarrhea, abdominal cramps when there is exposure to the milk, when milk is given. Okay, so a baby 10-month-old comes with vomiting, jaundice, and hepatomegaly, and signs of irritability when started weaning with fruit juice. Weaning means, what is the meaning of weaning? Is the gradual introduction of adult food to the child. When adult food is given to the child in the form of fruit juice which contain fructose, it contains fructose. So the diagnosis is hereditary fructose intolerance. Hereditary fructose intolerance. Okay, so the defective enzyme is aldolase B. This causes fructose 1-phosphate conversion into glyceraldehyde and DHAP, dihydroxyacetone phosphate. This is the action of aldolase B. Aldolase B. Now, whenever there is block in this aldolase B, the fructose 1-phosphate will accumulate, and this will inhibit the glycogen phosphorylase, and that causes the hypoglycemia. Accumulation of this 1-phosphate compound in the liver causes damage to the liver, also causes the jaundice and hepatomegaly. It affects the bilirubin metabolism, it causes the jaundice and hepatomegaly. Accumulation of this fructose 1-phosphate in the blood and the tissues. So there is aldolase B deficiency. This enzyme, it is defective in galactosemia, which is associated with congenital cataract. Along with these symptoms, there may be congenital cataract also. Okay, and when the baby is on the breast milk. Glucose 6-phosphatase deficiency, it is the von Gog's disease. Fructokinase deficiency, that is essential fructose urea. It is asymptomatic condition, essential fructose urea, which converts the fructose into fructose 1-phosphate. Okay. Which of the following enzyme deficiency is most likely to cause classical galactosemia in infant? Okay. See, the galactosemia, classical here, these are also causes of galactosemia. But classical galactosemia is due to the GALT, galactose 1-phosphate uridyl transferase defect. Glucose 6-phosphatase, it is deficient in von Gog's disease. It is defective in von Gog's disease. So galactose 1-phosphate uridyl transferase, it is defective in the galactosemia. Now see, galactose, it is converted into galactose 1-phosphate, and galactose 1-phosphate, it is converted into UDP galactose, and UDP galactose is converted into UDP glucose. This is the galactose metabolism. This is complete galactose metabolism. Now see, this is the enzyme required for this step, conversion of galactose 1-phosphate to UDP galactose. Okay, galactokinase, it is required for this step, galactokinase. And the epimerase, this is required for this step, epimerase. So accumulation of galactose 1-phosphate causes the symptoms or manifestations in the form of hepatomegaly, jaundice. These are the symptoms due to galactose 1-phosphate accumulation. And this galactose, it is converted into galactitol. Galactitol, that is also known as dulcitol in the lens, and osmotic effect of dulcitol or galactitol causes oil droplet cataract. Oil droplet cataract due to accumulation of galactitol or dulcitol in the lens. It is also in the galactokinase deficiency, but only cataract will be there, no other manifestation. In this is classical galactosemia. It is congenital cataract with the other manifestations, hepatomegaly, jaundice, etc. So what is the dietary advice should be given? The lactose-free diet should be given to the child. A baby refuses breast milk since the second day of birth, omits on forceful feeding but accepts glucose water, develops diarrhea on the third day. By fifth day, she is jaundiced with liver enlargement, and eye shows cataract. See, cataract, it is important. As far as biochemistry is concerned, cataract is important in the copper, cataract is important in the diabetes, cataract is important in galactosemia. Okay. Diabetes, galactosemia, copper. The Wilson's disease, copper, sunflower cataract. Copper is related with the sunflower cataract. Snowflake cataract, it is related with the diabetes because of sorbitol accumulation. Wait. See, copper excess, as in Wilson's disease, sunflower cataract. Sunflower cataract. And it is KF ring in the cornea. Fleischer ring, that is golden brown ring around the cornea in the decimate membrane of the cornea, KF ring. Then diabetes mellitus, accumulation of sorbitol and osmotic effect of sorbitol causes snowflake cataract. Okay. While the galactosemia, the classical galactosemia, there is accumulation of dulcitol, which is also known as galactitol, and it causes oil droplet cataract. Okay, so this is very, very important. So positive Benedict test, this is the positive Benedict test. It is positive. The urinary reducing sugar was positive, but the blood glucose estimation by GOD, glucose oxidase method, was found low. So this glucose oxidase method only measure the beta D glucose. That's why glucose, it is positive, low glucose in the blood. Blood glucose estimated by the glucose oxidase method was found low. So it is not glucose which is excreted in the urine because it is low. So it is the reducing sugar. It is because of another reducing sugar. That's why Benedict test is positive. So galactose also a reducing sugar. So see the history: refuses the breast milk, jaundiced, diarrhea, liver enlargement, Urinary reducing sugar was positive. This met the diagnosis of the galactosemia, which is due to galactose 1-phosphate uridyl transferase defect. Fructokinase, it is only excretion of fructose. So it is not the answer. It is von Gerk's disease. There is no excretion of any sugar in von Gerk's disease. This is hereditary fructose intolerance, but there is no cataract in the hereditary fructose intolerance. Okay. So answer is galactosemia with this defect, galactose 1-phosphate uridyl transferase. Which vitamin is deficiency? Try to answer this question. It is very easy. Which vitamin is deficiency? Vitamin A deficiency causes xerophthalmia. Xerophthalmia. Nyctalopia, xerophthalmia, corneal xerosis, conjunctival xerosis, and blindness. So vision related problem. Then defect in spermatogenesis. Then the what is known as phrinoderma. It is due to vitamin A deficiency. Niacin, diarrhea, dementia, dermatitis. Vitamin C, scurvy. Scurvy is the gum bleeding and the hemorrhagic tendencies. It is not hemorrhagic tendency. It is the features. So it is due to vitamin B2, riboflavin deficiency. Riboflavin deficiency. What are the deficiency manifestations of B2? B2. Okay. C. Angular stomatitis. Angular stomatitis. Chelosis. Glossitis. Magenta tongue. Magenta tongue. Red tongue. Then eye related symptoms, keratitis, circumcorneal vascularization, conjunctivitis, seborrheic dermatitis. These are the features of B2 deficiency. Riboflavinosis. These are the features of riboflavinosis. Okay. So B2 deficiency, riboflavin, active form FAD, FMN. These are the active form. Vitamin K supplementation will help a neonate suffering from. So it is prophylactically given in the neonate to prevent any bleeding tendencies. So here answer is hemorrhagic diseases. Phylloquinone, menaquinone, menadione is given 1 milligram intramuscularly. Now this is again an important question, Gaucher's disease. So before this Gaucher disease, we discussed the one, that is niacin, thiamine pyrophosphate, means thiamine. These are the high rated topic for any entrance examination, niacin, thiamine. Now this Gaucher's disease. Typically the crumpled tissue paper appearance in microscopy. This is the typical crumpled tissue paper appearance. Okay, Gaucher's disease. So remember this. So first answer this question. Enzyme deficient in Gaucher's disease is beta glucosidase. Another name is glucosidase. Another name is glucocerebrosidase. Glucocerebrosidase. And there is accumulation of glucocerebroside, that is known as glucosyl. That is known as glucosyl ceramide. Accumulation of glucosyl ceramide in the lysosome. So it is lysosomal storage disorder. It is lysosomal storage disorder. It is lipid storage disorder. So glucosyl ceramide. Glucosyl ceramide means glucose plus fatty acid plus sphingosine. Ceramide means fatty acid plus sphingosine. So it is glycolipid which is accumulated in the tissues. Okay, Gaucher's disease. It typically affects the bone marrow, liver, and spleen. Bone marrow, liver, and spleen. So it causes hepatosplenomegaly. It causes the involvement of bone marrow. So it causes the pancytopenia. There is anemia, leukopenia, thrombocytopenia, and hepatosplenomegaly. It involves the larger bones. So there is anemia, then thrombocytopenia, hepatosplenomegaly. So lysosomes are loaded with the glucocerebrosides that gives the crumpled tissue paper appearance. crumpled tissue paper appearance of lysosomes on microscopy, and the X-ray of the larger bone, they causes the avascular necrosis of the femur. They causes the avascular necrosis of the femur, and it gives the Erlenmeyer flask deformity. It gives the Erlenmeyer flask deformity. This is Erlenmeyer flask. So it is known as Erlenmeyer flask deformity on X-ray. Microscopy, crumpled tissue paper appearance. Okay, avascular also causes the fractures of the bone. Okay, so this is Gaucher's disease. Remember the mnemonic, Gaucher is a bro. It is a bro, cerebrosidase, defect in the cerebrosidase. It is the most common lipid storage disorder, lysosomal storage disorder. So these are the different lysosomal storage disorder. Gaucher's disease, it is beta glucosidase which is defective. There is accumulation of glucocerebrosides. Niemann-Pick disease, it is sphingomyelinase which is defective and accumulation of sphingomyelin. There is hepatosplenomegaly in this disorder, hepatosplenomegaly. And the characteristic feature of this disorder is the cherry red spot on the macula, except in K, G, Gaucher's disease, and F, except KGF. Cherry red spot is there on the macula. It is because of accumulation of lipids in the retina. So retina appears pale, and the center, that fovea, appears as a bright spot. So that is cherry red spot on the macula. It is seen in all other disorders except KGF. Don't you watch the movie KGF? Yes. So Graves disease, Fabry's disease, and Gaucher's disease, there is no cherry red spot. Okay. So, and in Tay-Sachs disease, there is no organ involvement, no organomegaly. This is GM2 gangliosidosis. Tay-Sachs disease, it is due to the defect in hexosaminidase A. There is no organomegaly, but when it involves the both A and B, hexosaminidase A and B, it causes there is hepatosplenomegaly. Along with progressive neurological impairment, which is in the Tay-Sachs disease, there is organomegaly. Okay, so these are the defects. So of this table, just remember these names. So Gaucher's disease, it is glucocerebrosidase, which is defective, accumulation of glucocerebroside. Niemann-Pick disease, sphingomyelinase is defective. There is accumulation of sphingomyelin. There is hepatosplenomegaly. Then the Tay-Sachs disease, it is GM2 gangliosidosis. There is no organomegaly, but there is progressive neurological involvement, and there is GM2 ganglioside which accumulates. Fabry's disease, it is GM1 gangliosidosis, and it is presented with angiokeratomas. Okay, and these are the enzymes which are deficient in these disorders. So see, a patient presented with refractory anemia. Histological picture is shown with cells in the bone marrow. Which of the following enzyme is deficient? Refractory anemia and crumpled tissue paper appearance. This is a classical feature of Gaucher's disease. Which one is defective here? It is glucocerebrosidase. A child presented with difficulty in vision. On examination, cherry red spot on macula. See, there is no cherry red spot in the KGF. So, cross the Gaucher's disease. Then, in the no organomegaly, identify the disease. There is cherry red spot in Tay-Sachs disease. There is cherry red spot in the Niemann-Pick disease, but not in Hunter. No cherry red spot in the Hunter disease. Corneal clouding is also not there in Hunter disease. No cherry red spot. It is mucopolysaccharidosis. So it is different domain. Now Tay-Sachs and Niemann-Pick. Niemann-Pick is associated with hepatosplenomegaly. Okay, but Tay-Sachs disease, there is no organomegaly. It is GM2 gangliosidosis. The second disease is Sandoff disease. In Sandoff disease, there is involvement of organs. The answer is Tay-Sachs disease. Which of the following is considered as universal methyl donor in the biochemical reaction? We already discussed this. Which of the following is universal methyl donor? Yes, adenosyl methionine. And the universal sulfate donor, TAPS. It is important for glycosamino glycan synthesis. Here answer is yes, adenosyl methionine. Okay. A person had meal at 8 p.m. and record blood glucose at the 7 a.m. in the next day, which was 180 milligram per deciliter. What is the source of glucose in this patient? So, what is the source of glucose? See, dietary glucose will provide the glucose for 2 to 4 hours, up to 2 hours or 2 to 4 hours. Mainly it is up to 2 hours. Okay, up to 2 hours. Then hepatic gluconeogenesis, it will provide the glucose after 12 hours. After 12 hours. Okay. In 12 to 18 hours, the gluconeogenesis is important. Hepatic glycogenolysis, it is important for 4 to 16 hours. It will maintain the blood glucose for 4 to 16 hours. Muscle glycogenolysis will not give you glucose because there is absence of glucose 6-phosphatase enzyme in the muscle. So what is answer? What is the gap? 8 p.m. to 7 a.m. is 11 hours. So here answer is hepatic glycogenolysis. Answer is hepatic glycogenolysis. See. So the well-fed state, then early fasting, then fasting, then starvation and prolonged starvation. Okay. So in well-fed state, it is up to 4 hours. Okay. Early fasting, it is 4 to 16 hours. Okay. Then fasting, it is 16 to 48 hours. This is roughly, this is not exact timeline. Okay. Starvation, it is 2 days to 5 days. And prolonged starvation, it is more than 5 days. So for this period of time in well-fed state, it is mainly the dietary glucose, and the body will synthesize the glycogen, body will synthesize the lipid. Body will synthesize the glycogen, body will synthesize the lipid. Early fasting state, it is provided by the liver glycogenolysis, breakdown of glycogen. It is provided. In between the meal, the sugar level or glucose level is maintained by the liver glycogenolysis. Fasting 16 to 48 hours. It is mainly by the gluconeogenesis. It is mainly by the gluconeogenesis. So gluconeogenesis will start in 12 to 18 hours. It will start in 12 hours, mainly 12 to 18 hours. In 2 days to 5 days, the fatty acids, they are principally utilized as a source of energy. Then ketone bodies, they are utilized. And in the prolonged starvation, it is muscle proteins, muscle proteolysis. It is muscle proteolysis. What are the important sources for the different organs? Wait. So brain will utilize glucose in fasting, in fed state, in fasting, and in starvation. It will utilize glucose. But in prolonged starvation, it utilizes the ketone bodies. In prolonged starvation, glucose will utilizes the ketone bodies. Okay. Liver, it will not utilize the ketone bodies. Liver utilizes the amino acids. It will utilizes amino acid. Okay. Liver utilizes amino acid, then fatty acids and fatty acids. Skeletal muscle, heart. They are mainly utilizes the fatty acid and ketone bodies. Fatty acid and ketone bodies. Liver and heart muscle. RBCs, there is no other option for RBCs. It will utilizes glucose and glucose. So these are the important organ. Brain will utilize ketone body in the prolonged starvation. Okay, and in starvation it also started utilizing the ketone bodies. A 10-year-old girl presented with, now we are shifting to the other topics. Okay, girl presented with exercise. 10-year-old girl presented with excessive tiredness, poor appetite, inability to concentrate, and tingling sensation. Inability to concentrate, this is a classical picture in our classroom. Okay, inability to concentrate on the things. And we physically sit on the classroom and mentally we are thinking about the other things. Okay, so 10-year-old girl presented with excessive tiredness, poor appetite, inability to concentrate, and tingling sensation. On examination, there was pallor. Pallor indicates the hemoglobin level. It is seen in the lower palpebral conjunctiva by everting the lower eyelid. Okay, so there was pallor. Lab investigation revealed the hemoglobin, decrease in the hemoglobin, ferritin, and MCV. These are the indicators for the iron status of the body. Ferritin is the indicator of the iron. It is the indicator of the iron store of the body, ferritin. Okay, the total iron binding capacity, TIBC, increased. Which of the following is the deficient? Now rule out one by one option. Zinc is not related with anemia. Zinc is related with dermatitis, that is known as acrodermatitis. Acrodermatitis enteropathica. Copper is related with anemia. But along with the anemia, copper is also related with the Menkes disease. It is related with the Wilson's disease. It is related with cardiovascular manifestation. It is related with the large vessel disorder. Copper. Calcium is related with the calcium deficiency related with the CATS. CATS means convulsion, arrhythmia, tremor, tetany, and spasm and stridor. Convulsion, arrhythmia, tetany, tremor, stridor, spasm. Okay. So answer here is, simple answer is here, iron. Answer is yes. Adhikari, D is the answer. Thank you. Okay. That means I am audible and visible to all of you. Okay. So iron. How iron is absorbed? All of you know it is absorbed from the duodenum. And how it is absorbed? So absorption of iron is very, very important. This is duodenal enterocyte. Suppose this is duodenal enterocyte. In diet, it is present in the ferric form. This ferric iron is converted into ferrous form by the vitamin C or by the duodenal cytochrome B. This iron absorption is very, very important. Okay, so ferric is converted into ferrous. Now with the help of one transporter that is known as divalent metal ion transporter. It is known as divalent metal transporter 1, which is responsible for transport of divalent cations. For example, iron, zinc, lead, and iron, zinc, lead, copper. So it is important for the transport of these divalent cations. So it is transported inside the enterocyte. So this is ferrous. It is converted into ferric form and it is stored. It is stored in the form of ferritin. It is stored in the form of ferritin. Now this ferrous is transported out by the one protein that is known as ferroportin. Ferrous is transported out through the basolateral membrane of the enterocyte through the ferroportin, and this ferrous is again converted into ferric form via the ceruloplasmin. Ceruloplasmin. That's why ceruloplasmin. That's why copper is important here for conversion in ferrous into ferric form and its transportation in the form of transferrin. Its transport in the form of transferrin. So this is ion absorption. It is regulated by the hepcidin level. It is regulated by the hepcidin level, iron level. It is maintained by the this regulatory molecule. Okay. So iron deficiency, it is indicated by the serum iron level, serum ferritin level, then MCV, mean corpuscular volume, decreases, mean corpuscular hemoglobin concentration decreases, then total iron binding capacity, TIBC, it is more than 360 milligram per DL. It is more than 360 milligram per deciliter. These are the some parameter which are helpful in the diagnosis of iron deficiency anemia. So there is iron deficiency when there is chronic blood loss, when there is increased demand as in the pregnancy and lactation. That's why prophylactically 100 milligram of iron is given in the pregnancy. Okay. So whenever increased demand, whenever there is chronic blood loss or hookworm infestation, there is iron deficiency anemia. A young child presented with history of rashes around the eyes. Now the dermatitis, okay, rashes around the eyes and mouth, Mother also complain of impaired night vision. Night vision means first thing in your mind should be vitamin A. Okay. The patient and complains that child fall down last month and the wound healing is not proper. Which of the following is deficient? Now, which vitamin is important for the night vision? It is vitamin A. There is no option in the vitamin A. Okay. Now, which are important in the wound healing? For wound healing, which vitamins are important? Vitamin C is important. Then hyaluronic acid is important and zinc is important. Vitamin C, hyaluronic acid and zinc, these are important for the wound healing. Okay. So night vision, it is important, vitamin A. Now, there is history of rashes around the eyes and mouth. This is dermatitis. Dermatitis is there. So see, copper is presented with Wilson's, Menkes, anemia and aortic aneurysm. Zinc deficiency, there is dermatitis, that is known as acrodermatitis. Acro means acral part of the body, distal part of the body. So acrodermatitis enteropathica. Selenium, it is related with Cation disease. Cation disease is cardiomyopathy. Cobalt is not as such not related with any disorder. Copper, Wilson's disease, Menkes disease, previous anomaly, anemia. So dermatitis, there is no dermatitis in other. So zinc is the option here. Also, it is required for the wound healing. Zinc is required for the wound healing. Zinc is required for the maintaining the level of retinol binding protein and maintaining the level of vitamin A in the serum. Zinc is required for this retinol binding protein and maintaining the serum vitamin A level. So it is important. Okay. What is there? Yes. Wait. Power off. Don't know what is going on. I don't know I am audible or visible. Please give the thumbs up. Just wait 1 minute. Okay, so here answer is zinc. Now zinc is a cofactor for which vitamins? Zinc is a cofactor of which enzyme? It is cofactor for more than 300 enzymes. more than 300 enzymes. Okay, so that includes carbonic anhydrase, cytosolic superoxide dismutase, that include carbonic anhydrase, cytosolic superoxide dismutase, then carboxypeptidase, and RNA polymerase, and number of enzymes, that is dehydrogenase, specifically alcohol dehydrogenase. So it is important factor, important as a prosthetic group or cofactor in the number of enzymes, more than 300 enzymes. So it is main function is antioxidant because it is involved with the superoxide dismutase activity. It is involved with the superoxide dismutase activity. So carbonic anhydrase, lysyl oxidase, copper is required. Carboxylase, don't know. Kinase, mainly the magnesium, and the manganese is required. Okay. A 13-year-old boy reported with jaundice, fatigue, muscle stiffness, tremor, and behavioral changes. Examination revealed an enlarged liver and KF ring, Kaiser ring was noted. What is probable diagnosis? What is probable diagnosis? There is one, press any key to cancel, to power off. Just wait. Okay, a 13-year-old boy, jaundice, fatigue, muscle stiffness. The KF ring, Kaiser-Fleischer ring, is the important manifestation in the Wilson's disease. We'll discuss the Wilson's and Menkes now. Acrodermatitis enteropathica, it is due to zinc deficiency. Tetany, it is due to decrease in the calcium level. Okay, so this is the golden brown ring in the cornea, in the decimate membrane, that is known as KF ring. It is the typical feature of the Wilson's disease. Another name of Wilson's disease is hepatolenticular degeneration. Hepatolenticular degeneration. It is another feature of this Wilson's disease, hepatolenticular degeneration. This is another name. Okay, hepato means involvement of liver. Lenticular means lenticular nucleus of the brain. So there is involvement of liver and brain. There is cataract, that is known as sunflower cataract. There is golden brown ring around the cornea in the decimate membrane. In the decimate membrane of the cornea. This is the feature, KF ring. It is due to copper excess. There is excess of copper and there is decrease in the ceruloplasmin level. Ceruloplasmin level in the Wilson's disease. See this. This is very, very important. This is very, very important. Menkes disease, Wilson's disease. One is due to mutation in ATP7A, while other is due to mutation in the ATP7B. These are the, wait. Just wait. It's okay now. Okay. So Wilson's disease, Menkes disease. One is copper deficiency. Here is the deficiency of copper. Here is the excess of copper. Here is the excess of copper. These are due to mutation in the ABC protein, ATP binding cassette transporter protein, ABC proteins, mutation in the ABC proteins. So whenever there is defective absorption of the copper from the intestine, it leads to the Menkes disease, means there is decrease in the copper. whenever there is defect in the excretion of copper into bile, so there is excess of the copper increases, okay, and its incorporation into ceruloplasmin and other protein decreases, so that causes the Wilson's disease, that is hepatolenticular degeneration. This is copper excess, this is copper deficiency. Here there is jaundice, hepatomegaly will be there, AF ring will be there, sunflower cataract will be there. In Menkes disease there is brittle hair, pluckable, easily pluckable brittle hair, and hypopigmentation will be there. What are the enzymes which are related with the copper? It is very important. Ceruloplasmin, then cytochrome oxidase, then catalase, then ALA synthase, the first step in the heme synthesis, ALA synthase, then superoxide dismutase, that is cytosolic, okay, mitochondrial superoxide dismutase, there is manganese, okay, then tyrosinase and lysyl oxidase. These are the important enzymes which are related with the copper, and the functions they are related with this. So this is antioxidant function, this is for synthesis of melanin, it is the collagen cross linking and synthesis of collagen, lysyl oxidase. It is important in collagen cross linking. It is important for formation of cross links between the hydroxylysine. It is the cross links between the aldols of the hydroxylysine. So it is important in the collagen cross linking and strengthening. So these are the important function. Ceruloplasmin, it is related with the iron, it is related with the copper. This is electron transport chain. This is detoxification reaction. This is related with the heme synthesis. So as it is related with the two important proteins, that is ALA synthase and ceruloplasmin, it causes anemia. Deficiency causes anemia. So there is anemia in the deficiency of copper. Why anemia? Because it is heme synthesis and ceruloplasmin, conversion of ferrous into ferric and its incorporation into transferrin. Okay, as it is involved in the lysyl oxidase in the Menkes disease specifically. So lysyl oxidase, there is involvement of vessels, aneurysm will be there because of defective collagen synthesis. This is important. Okay, so these are the important things related with the copper. Hormones that regulate serum calcium level. It is very easy. Which hormones that regulate the serum calcium level? So calcitonin, vitamin D, and parathyroid hormone. So vitamin D, parathyroid hormone, calcitonin. So vitamin D, parathyroid hormone, calcitonin. Vitamin D increases the absorption of calcium from the intestine. It increases the absorption of the calcium. Parathyroid along with vitamin D increases the absorption. It decreases the absorption from the intestine. Calcitonin responsible for decrease in the serum calcium level. Answer is A. Yes, calcitonin, vitamin D, and parathyroid hormone. Then renal tubules. Vitamin D, it is important in reabsorption. It increases the reabsorption. Parathyroid hormone increases the reabsorption from the renal tubule. It decreases the renal reabsorption. Calcitonin. Then bone. These are the three target tissues. Bone. Vitamin D causes the mineralization of bone. Parathyroid hormone causes the demineralization of bone. And this is causes mineralization of bone. So ultimate effect is, what is the ultimate effect? Vitamin D increases the serum calcium level. Parathyroid hormone increases the calcium. Calcitonin decreases the calcium. This parathormone, it causes the excretion of phosphorus from the renal tubule. So parathyroid is responsible for excretion of phosphorus. So these three are related with the calcium and phosphorus. Glutathione peroxidase contain which metal? We already discussed copper. There were no glutathione peroxidase. In zinc, there were no glutathione peroxidase. Manganese, it is particularly related with kinase arginase. Okay, so and mitochondrial superoxide dismutase. Selenium, it is related with three important enzymes. One is this glutathione peroxidase. That's why it is antioxidant. Selenium, it is related with deiodinase. Deiodinase. Selenium, it is related with thioredoxin reductase. These are the three important enzymes related with the selenium. And the 21st amino acid selenocysteine, it is related with the selenium. Deficiency of selenium causes the Cation disease, that is cardiomyopathy. Cation disease. Copper, we already discussed the copper. It is related with ceruloplasmin. Cytochrome oxidase, it is related with catalase. It is related with ALA synthase. Superoxide dismutase, that is cytosolic superoxide dismutase. Tyrosinase and lysyl oxidase, copper. Zinc, mainly related with the carbonic anhydrase, superoxide dismutase, carboxypeptidase, RNA polymerase, and various dehydrogenase. It is related. Manganese, it is mainly related with arginase, kinase. Okay, so here answer is glutathione. Selenium is the answer. Cation disease is due to deficiency of selenium. Cation disease is due to deficiency of selenium. That is, there is cardiomyopathy in selenium deficiency. Okay. Zinc deficiency causes acrodermatitis. Acrodermatitis, involvement of acral part of the body, finger, nose, toes. In infant, there is involvement of buttock. Okay, acrodermatitis enteropathica. Copper, we already discussed the copper. Iron causes the iron deficiency anemia. If excess, it causes hemosidrosis, hemochromatosis. Iron excess, hemosidrosis, hemochromatosis. Hemochromatosis is a part of bronze diabetes. It affects the insulin. So there is diabetes. It causes the discoloration of skin, and one more is there. So that is known as bronze diabetes. Okay. Which is not a micro element of this, which is not a micro element. So see, calcium, when the requirement is more than 100 milligram per day, it is known as major element. It is known as major element. When the requirement is less than 100 milligram per day, it is known as minor element or micro element or trace element. And when its requirement is less than 1 milligram per day, it is known as ultra trace element. Ultra trace element that mainly include iodine, selenium, chromium, molybdenum, etc. Okay, so here calcium requirement is 800 milligram per day. Pregnancy and lactation, it is 1.5 milligram, 1.5 gram per day. So it is a major element. Selenium requirement is 50 to 200 microgram. Copper, it is 2 to 3 milligram per day. Zinc, it is 10 milligram per day. A 70-year-old male has bruising under the eyes. Which of the following vitamin deficiency lead to the easy bruising and bleeding gums? So this is easy bleeding gums, easy bruising. It is in the vitamin C deficiency, that is scurvy. Vitamin C, it is required for the answer is vitamin C. Okay, vitamin C, it is required for hydroxylation reaction. Hydroxylation of proline. So proline is converted into hydroxyproline and lysine is converted into hydroxylysine by prolyl hydroxylase. This is via lysyl hydroxylase. So vitamin C is required for this. Apart from this, it is an antioxidant important for various reaction for the amino acid, aromatic amino acid metabolism. It is required for the hydroxylation reactions. It is also important. This reaction, it is mainly important for collagen synthesis. And due to defective collagen synthesis, there is brittle blood vessels, brittle capillaries or fragile capillaries. So easily fragile, and that causes bruising and bleeding tendencies. That bleeding gums, the petechial hemorrhages on the skin. This is the manifestation of the scurvy. Apart from prominent costochondral junction, that is the scorbutic rosary. Apart from prominent costochondral junction. And in the advanced stage, it's called as pseudo paralysis because it causes joint effusion. Okay, so vitamin C, it causes the scurvy. And vitamin K is required for the gamma carboxylation. We already discussed this. The clotting factor, post translational modification of factor 2, 7, 9, 10. Then osteocalcine, then protein C, protein S, and the matrix GLA protein. It is associated with activation of this gamma carboxylation. Glutamate is converted into gamma carboxyglutamate, which combines with the negatively charged, this is negatively charged, and it combines with the positively charged calcium, and this complex is important in the coagulation. Conversion of prothrombin to thrombin, it is important. So it is important in the coagulation. So this is about the vitamin K. Which of the following helps in the wound healing? Wound healing, C. Whenever it is wound healing, it is vitamin C, it is hyaluronic acid, it is zinc, which is required principally for the wound healing. Okay. Vitamin A also has the role, but these are the three majors. Which of the following helps in the wound healing? Here, hyaluronic acid. Keratin sulfate, it is responsible for maintaining the corneal transparency. It is important. Dermatan sulfate is important for the skin and the shape of the vessels, shape of the walls and vessels. Then hyaluronic acid important in the synovial fluid. It is important in vitreous humor of the eye. It is important in the cell migration. It is important in the wound repair. Chondroitin sulfate, it is important in the cartilage. Okay, so this is the important functions of this. Then heparan sulfate, the next one is heparan sulfate. It has two important functions. One, it is important for charge selectiveness of glomerular basement membrane. It is important for anchoring lipoprotein lipase to capillary endothelium. It is also present in the synaptic vesicles. It is important in cell signaling. It is cell signaling, and it is present in the presynaptic vesicles. Okay, that is heparan sulfate. This is heparan sulfate. Heparin is the anticoagulant. So these are the functions of these glycosaminoglycans. So we will discuss this in short, and the next session, the tomorrow's session, will start with the acid-base disorder. Okay, we'll discuss this in short. So you can just identify whether it is acidosis or alkalosis. Okay, a 49-year-old lady admitted in medicine ward with complaint of chronic obstructive airway disease since years. On examination, she was cyanosed and breathless. Blood investigation reveals following result. pH is 7.21, PCO2 65, and bicarbonate is 34. So see, so 7.35 to 7.45 is the normal pH. Okay, normal PCO2 is 35 to 45 and normal bicarbonate level it is 22 to 28 millimole per liter. This is normal. Just now think about the whether it is metabolic acidosis or alkalosis. Okay, tomorrow we will discuss it in detail. So pH, if pH decreases, it is acidosis. See the here, it is 7.21 means it is decreases. So it is acidosis. Now rule out the alkalosis. Rule out the alkalosis. No, now the two options are left. Okay, so if it is more than 7.45, it is alkalosis. Alkalosis. If PCO2, consider PCO2 as a carbonic acid. If carbonic acid increase beyond the 45, if it is increased, it is respiratory acidosis. Respiratory acidosis. If it is decreased, it is respiratory alkalosis. Respiratory alkalosis. Bicarbonate, it is a base, alkali reserve, it is a base. If base increases, it is alkalosis. But this is metabolic component, so it is metabolic alkalosis. And if base decreases, it is metabolic acidosis. Metabolic acidosis. Now the factor or the parameter of these two, parameter which goes with the pH is the primary defect. Which goes with the pH. Now see, pH is 7.21, so it is acidosis. Now CO2 level is 65, means more than 45, so it is respiratory acidosis. So it is respiratory acidosis. Now bicarbonate is 34. So 34 means metabolic alkalosis. Metabolic alkalosis. So parameter which goes with the pH is the primary defect. So here it is respiratory acidosis. Acidosis, acidosis. So it is respiratory acidosis and this is compensation. This is compensation. Okay. So respiratory acidosis with compensation is the answer. Okay. See the second important disorder. A 17-year-old boy diagnosed with diabetes, brought to the hospital in semi-conscious state and abnormal deep rapid breathing. His plasma glucose was 673 milligram per deciliter. Urine shows positive Benedict and Rothera's test. This is positive Benedict test. This is positive Rothera's test. This is the purple ring. See the purple ring. So this is the Rothera's test. Okay. Blood investigation reveals following result. pH 7.21, PCO2 30 and the bicarbonate 16. Identify the disease. As there is increase in sugar and ketone bodies, both are positive. It is a case of diabetic ketoacidosis. It is a case of diabetic ketoacidosis. There is glucose in the urine positive and the ketone bodies in the urine positive. If only this test is positive, it is for the, it can be due to the starvation or it can be due to the branched ketoaciduria. But here both the tests are positive, so it indicates the diabetic ketoacidosis. Then the blood pH is 7.21 means metabolic. This is acidosis. This is acidosis. PCO2 is 30, 35 to 40 is the normal. So if carbonic acid decrease means respiratory alkalosis. Alkalosis and bicarbonate decrease means metabolic acidosis. So which goes with the pH is the primary defect. So metabolic acidosis, acidosis. So this is the primary defect. So this is a case of metabolic acidosis with compensation by the respiratory alkalosis. So it is a case of diabetic ketoacidosis, which is a cause of high anion gap metabolic acidosis. So here alkalosis, but alkalosis. So it is not respiratory. It is the metabolic component, that is the bicarbonate metabolic component. PCO2 is the respiratory component. So it is metabolic acidosis. So this is positive Benedict test, Rothera's test. So here answer is metabolic acidosis. So we'll discuss this tomorrow. What are the different buffer systems, how it is compensated, we'll discuss tomorrow. But see this is very, very important. If pH decreases, it is acidosis. If pH increases, it is alkalosis. If bicarbonate level decreases, this is base. If base decreases, it is acidosis. If base increases, it is alkalosis. PCO2, considered it is it with the dissolved carbonic acid. If carbonic acid decreases, means it is respiratory alkalosis. Carbonic acid decreases, respiratory alkalosis. If it is more than 45, it is respiratory acidosis. In this way, you can identify the acid-base disorder. The parameter who goes with the pH is the primary defect. So in detail, we will discuss it tomorrow. This is the part 1 for FMGE exam preparation. Okay, this is the part 1 for FMGE exam preparation. Daily हुआ होगा करेगा क्या? So we are discussing the important points or important topics and PYQs for the FMGE preparation. So this is the part 1. Tomorrow we'll take the remaining part. So this topic, today's topic was on the vitamins, was on the mineral, was on the carbohydrate metabolism, was on the some part on the protein metabolism, and the metabolic inborn errors. Mainly it is with the inborn errors. So these are the main topic, important topics. Read the topic or read the subject in the integrated way, okay, aligned with the other subject. So this is all about the today's session. Thank you.